Hello, good evening, everyone. And it's with great pleasure and honor I would like to invite for this excellent discussions on the best of SABCS and ESMO 2025. We have a pleasure to welcome the program convener, Dr. Kunal Jain, sir, who is Associate Professor and Head Department of Medical Oncology at the prestigious Dayanand Medical College and Hospital and associated with American Oncology Institute, Ludhiana. So once again, ladies and gentlemen, good evening, and may I request Dr. Kunal Jain, sir, to please come forward with your setting of contacts and opening remarks, please. Dr. Kunal, sir, over to you.
Thank you. Thank you, Taranji and team from Horizon. Happy New Year to everyone, and a very good evening to all the faculty members who have joined for this webinar. We all know about the data that keeps that is generated not only in oncology but in the field of medicine, and especially when we are talking about oncology. So many trials keep coming up day in, day out. And meetings like these give us an opportunity to make sense of some of that data. So we have very esteemed faculty from a lot of places from Punjab and from Chandigarh Tri-City area. And also we have two excellent speakers. I'm extremely thankful to Dr. Sushil Beriwal for accepting the invitation for this webinar, and also Dr. Bharat Vaswani, who will be later on giving updates about the SABCS. So we have planned for 2-day session. Today's session will mainly be focused on breast cancer. All types. We will gradually be looking at various subtypes, positive disease, ER positive disease, both in early as well as advanced setting. We are now kind of spoiled with choices for treating our patients with a lot of malignancies and including breast cancer. And although there are approaches where we are trying to escalate treatment for some settings, especially in the metastatic setting where we are adding more drugs to improve the survival. But there has also been a push for de-escalation of treatment in some of the settings, both with medicine as well as surgery and also radiation. So I think it is a good thing to have a balance between these strategies. And while we have trials which will challenge the previous notions of how we were treating the patients, it is important that we keep learning as we keep treating our patients. So without further ado, I'll invite our first speaker, who's Dr. Akansha, our colleague at Medical Oncology Department at DMC, for her first talk on role of anti-HER2 agents in early breast cancer.
So a very good evening to all. Thank you, Dr. Kunal and the organizers for giving me this opportunity. Are my slides visible and are they moving?
Yes.
Okay, so
Yes.
Sure, thank you. So without any ado, I'll take this presentation. So this is about the recent advances in the management of HER2 positive early breast cancer and the role of adjuvant trastuzumab. So to start with, who are the patients for HER2 positive early breast cancer who should receive the preoperative systemic therapy? So these patients are either with a tumor size, primary tumor size of more than 2 centimeter, or if they have node positive disease, regardless whether it is hormone receptor positive or negative, they should receive neoadjuvant chemotherapy with the addition of dual HER2 blockade, that is trastuzumab and pertuzumab combination. So to support this, we have two studies. One is the Neosphere study and other is the Trifina study. So we'll discuss that. So this is for the studies on neoadjuvant role of trastuzumab and pertuzumab in HER2 positive early breast cancer. So talking about the Neosphere study first. So this study took patients of early breast cancer. Basically, this study took patients of all the non-metastatic breast cancer who had tumor size of more than 2 centimeter. So they were divided into 4 arms for the neoadjuvant systemic therapy, where one arm received taxane and trastuzumab, one received taxane and pertuzumab alone, one received taxane and combination of dual HER2 blockade, that is trastuzumab and pertuzumab, and the other arm received only trastuzumab and pertuzumab. So this was given for 4 cycles, after which surgery was done and after which in the adjuvant setting anthracycline based regimen was given. The primary endpoint was PCR. Talking about the second study, which is the Trifina study. So this also took into account similar patients of operable breast cancer. They divided the patients into 3 arms, where 2 arms received anthracycline followed by THP, and the third arm received TCHP, that is taxane carboplatin with dual HER2, that is trastuzumab and pertuzumab. PCR was assessed at the surgery and adjuvant trastuzumab was completed for 1 year. Although primary endpoint for this study was cardiac safety, but in this we'll be just talking about the PCR rate in these 2 studies. So these were the results. If you look at the first Neosphere trial, the PCR rates was highest with the combination of taxane and dual HER2. That is, with the pertuzumab, trastuzumab and taxane, the PCR rate was 45% in HR negative population and 39% in HR positive. And this was the highest amongst all the comparator arms. And if you look at the Trifina study, again the PCR rate was highest, which was 63% in TCHP arm, which was highest as compared to only 55% in other 2 arms which contained anthracycline. So this concluded that pertuzumab added to trastuzumab increases the PCR rate regardless of the hormone status and regardless of the chemotherapy partner. It means that the anthracycline free regimen can be used in neoadjuvant setting in such population. To further support this, we have phase 3 train 2 study, which is neoadjuvant chemotherapy with or without anthracyclines with dual HER2 blockade in HER2 positive early breast cancer. Again, stage 2 and stage 3 patients with good performance status and ejection fraction of more than 50% were taken. They were divided into 2 arms, where one arm received 9 cycles of TCHP and other arm received 3 cycles of anthracycline plus Trastuzumab and Pertu combination, followed by 6 cycles of TCHP, after which the surgery was done. And trastuzumab was continued for 1 complete year, and endocrine therapy was added after surgery if it was hormone receptor positive. The primary endpoint was PCR and secondary endpoints were safety, recurrence-free survival and overall survival. So these were the results. If you look at the PCR, which was the primary endpoint, these 2 arms had similar PCR, which was to the tune of 67 to 68%, which is quite high. So high rate of PCR was seen with or without anthracyclines, and this outcome was consistent across all the levels of the subgroups, irrespective of the T stage, irrespective of the nodal staging, irrespective whether it was hormone receptor positive or negative. Also, there was no difference in the event-free survival and overall survival. So based on this study, we prefer and use anthracycline-free regimen, that is TCHP regimen, in the neoadjuvant setting with the HER2 positive breast cancer. Talking about the safety in the train 2 study at 3-year follow-up, the main side effects which were with the anthracycline was neutropenia, which was to the tune of 60%. But another notable toxicity was cardiotoxicity, which was seen as LVF decrease of more than 10% or LVF to less than 50%, which was seen in 36% of the patients who received anthracycline as compared to only 22% who received anthracycline-free regimen, that is TCHP regimen. Also, LVF decline did not improve during the normal follow-up in 1/3 of the patients, which further supports the use of TCHP regimen as compared to anthracycline-based regimen in such subset of population. So this was all about the neoadjuvant setting. Now coming on to the adjuvant setting, talking about the affinity trial, the role of pertuzumab, trastuzumab and chemotherapy versus only trastuzumab and chemotherapy in HER2 positive early breast cancer. So the patient, this was also phase 3 trial where the patients any node positive or node negative more than 1 centimeter were taken, and after surgery they were divided into 2 arms. Before that, it was ejection fraction was assessed, and that should be more than 55% to be eligible for this trial. So they were divided into 2 arms. One arm received chemotherapy along with a combination of trastuzumab and pertuzumab, and the comparator arm received only chemotherapy with only trastuzumab plus placebo. Primary endpoint was invasive disease-free survival, and secondary endpoints were overall survival, distant recurrence-free survival, DFS, the cardiac safety, and the quality of life. So we have now the final long-term overall survival benefit. We have the overall survival analysis at 11.3 years, which is the updated analysis. And this graph, it shows significant improvement in the overall survival. The 10-year overall survival was 91.6% in the arm containing pertuzumab as compared to only 89.8% in the arm not containing pertuzumab, that is only trastuzumab. So with the addition of pertuzumab to trastuzumab and chemotherapy, these patients with HER2 positive operable breast cancer, this confirms the efficacy of dual HER2 blockade, especially in patients with node positive disease. So long-term follow-up in the curative setting also shows that when pertuzumab is added to trastuzumab and chemotherapy, there is 21% reduction in the risk of death. But the point to note here is that it was seen only in the node positive subset. So talking about the invasive disease-free survival, there was improved IDFS, which was maintained in the updated analysis at 11 years, and the 10-year IDFS event-free rates were 87% versus 83%, again favoring the pertuzumab combination arm. So this benefit continued to be clinically meaningful in the node positive subgroup only, while no benefit was seen in the node negative subgroup, and there were no new cardiac safety signals which emerged in this population or this trial. So coming on to the next study, which is the Catherine study, which is trastuzumab emtansine versus trastuzumab alone as adjuvant therapy for HER2 positive early breast cancer. This is also a phase 3 study where similar patients were taken, and after surgery, if the patients had residual invasive disease in either breast or axillary nodes or both, they were divided into two arms, where one arm received TDM1 at the dose of 3.6 mg per kg given 3 weekly for a total of 14 cycles, and that was compared to trastuzumab alone, which was given for 14 cycles. The primary endpoint was invasive disease-free survival, and secondary endpoints were distant recurrence-free survival, overall survival, and safety. So these were the results. The 3-year IDFS was better. It was 88% in TDM1 arm as compared to only 77% in the trastuzumab arm. Also, distant recurrence, locoregional recurrence, and contralateral breast cancer were all lesser in the TDM1 arm as compared to trastuzumab. If you look at the 3-year event-free rate, it was better. It was 89% in TDM as compared to 83% in the trastuzumab, which shows that distant recurrence was lesser in the TDM1, and the overall survival was also better. Now we even have the 7-year overall survival, which is shown as 84% versus 89% in favor of TDM1 arm in this subset who have the residual invasive disease after surgery. So TDM1 is better than trastuzumab in the adjuvant setting in such subset of population. So coming on to the grade 3 events. So with the use of TDM1, we have certain grade 3 events. We have more of the side effects like fatigue, nausea, thrombocytopenia, and altered LFTs. And discontinuation rate was slightly higher, which was 18% as compared to only 2% in the trastuzumab arm. So with the use of various HER2 targeted therapies, now we have various options available. We have trastuzumab, pertuzumab, we have TKIs like lapatinib, neratinib, we have TDM1 and other ADCs. We always have to take into account that what are the side effects. So with the combination of trastuzumab and pertuzumab, although rare, but we have to monitor the cardiac function because cardiotoxicity is seen in such subset of patients. So LVF have to be monitored timely to assess the cardiac function. With neratinib, we have diarrhea, rash, and rarely we have altered LFTs. And with TDM1, as we have discussed, apart from fatigue and nausea, we have thrombocytopenia, altered LFTs, and neuropathy as the side effect. So this was about the adjuvant setting. So we have discussed about the neoadjuvant setting. We have discussed about the adjuvant setting. Now we have, it's time to discuss about the newer approach. That is, now we have de-escalation approach in this HER2 positive subset of population. So this is ADAPT TP trial, which is de-escalated neoadjuvant TDM1 plus minus endocrine therapy versus trastuzumab plus endocrine therapy in triple positive early breast cancer. So this is a phase 2 trial. So here what the trial did was that it gave TDM1 with or without endocrine therapy in the neoadjuvant setting, and this was compared to trastuzumab plus endocrine therapy in the neoadjuvant setting. And if the PCR was achieved, the whole idea was that whether these patients who have achieved PCR, whether adjuvant chemotherapy can be omitted in this subset of population. So the PCR rate was quite good with TDM1, that is 41% with the TDM1 as compared to only 15% with the trastuzumab, and there was no difference in the overall survival even if the adjuvant chemotherapy was not given. So with excellent survival, this trial supports the de-escalation therapy in such subset of population who have achieved PCR with neoadjuvant TDM1. But this is a phase 2 trial only. Coming on to another trial, which is COMPASS HER2 trial, which is neoadjuvant THP and adjuvant HP in patients achieving PCR. So this is again a phase 2 trial with the de-escalation approach which was tried. Again, stage 2 and stage 3 patients were taken who received 4 cycles of THP, and the taxane was choice. It was either paclitaxel, docetaxel or nab-paclitaxel, post which surgery was done after 12 weeks. And patients who achieved PCR, they only received HP, and endocrine therapy and radiation therapy was allowed if appropriate. And in patients who did not achieve PCR, they received adjuvant chemotherapy plus the HER2 targeted therapy. Primary endpoint was recurrence-free survival, and secondary endpoints were IDFS, RFI, overall survival and safety. So the point here to note is that here we are just giving 4 cycles of THP as compared to usual 6 cycles of TCHP which we give. So the results of this trial was that with 12 weeks of THP, the PCR rate was quite good. It was 64% in HR negative and 33% in the HR positive population. So this trial shows that in patients who have no residual disease at surgery, they can forego further chemotherapy to avoid the toxicity. But longer follow-up is needed to assess the long-term outcomes with this approach. Coming on to my last slide, so we have various future trials for HER2 positive which are ongoing. One is IM Passion, which is seeing the role of atezolizumab in combination with anthracycline and THP, the primary endpoint being PCR. We have another APNEO trial, which in the neoadjuvant setting, it is seeing whether TCHP plus atezolizumab versus anthracycline based chemotherapy with atezolizumab is feasible, whether it leads to better EFS or not. Then we have Destiny Breast 11 trial, which in the neoadjuvant setting is examining the role of TDXT as compared to anthracycline followed by THP, the primary endpoint being PCR. We again have Destiny Breast 05 trial. This is for the adjuvant setting, where with the residual disease after neoadjuvant setting, we usually give TDM1, but this is being compared with TDXT with IDFS as the primary endpoint. And the last is Estefania trial, which is again comparing patients with residual disease after neoadjuvant therapy, whether they should receive only TDM1 or atezolizumab in combination with TDM1. But these are ongoing trials and the results are yet awaited. So this is all from my side. I thank you all for patient hearing. Thank you again, Dr. Kunal, and thank you, Sipla, for providing the slides to me. Thank you.
Thank you, Dr. Akansha, for first of all finishing in time also. So that is, I think, the first talk finishing in time is always good. About de-escalation, I think one other important thing is the 2 trials which have shown that we can omit carboplatin, the NeoCAR HP, CARP HP, and the second is Helen 06, where we can use nab-paclitaxel also with similar results with pertuzumab and trastuzumab. And I think pertuzumab is kind of weakest in adjuvant setting, where the proportion of benefit that we are used to see in other settings is not there. But still in adjuvant settings, I think 2%, it's just about 2% absolute benefit, so which is kind of acceptable and has led to its approval.
I totally agree, sir, that NeoCARP study, especially in patients with stage 2, where we can avoid carboplatin, NeoCARP study is beneficial in such patients.
Ma'am, I have one question.
Yes, please.
Ma'am, in which subgroup patient we should choose for TCHP, and which subgroup of patient we choose for AC or for PECLI plus HER2 targeted therapy?
So basically, if you look at the TRAIN 2 study, all the subgroups, irrespective of the nodal burden and irrespective of the T stage, all the subgroups, they benefited with TCHP, and there was similar overall survival with anthracycline. So in almost all the subset of patients, we can avoid anthracyclines. There are certain practitioners which use anthracycline, especially in patients with heavy nodal burden. But personally, I just go with TCHP based on TRAIN 2 study, which has shown the similar overall survival in the anthracycline-free regimen also.
Thank you,
This
ma'am.
is an ongoing debate, always anthracycline or free anthracycline. So we'll move to the next session, which is a very important session and which has been the cause of debate, more of a healthy debate during our tumor board sessions, where we are discussing about post mastectomy radiotherapy, especially with the recent data. So for this talk, again, as I mentioned earlier, I'm extremely thankful to Dr. Sushil Beriwal, and I'll invite the chairpersons for this session, Dr. Sandhya Sood, who's in charge of radiotherapy, Dr. G.S. Barad, who is professor and head surgical oncology and overall in charge of our cancer center, then Dr. Ritu Agarwal, who is also senior consultant radiation oncologist, and Dr. Manjinder. So if Dr. Sandhya can just briefly, because a lot of the participants may not be aware or may not be knowing about Dr. Sushil Beriwal. So if you can, ma'am, please quickly introduce sir. Is Dr. Sandhya there?
Ma'am, can you, yeah, ma'am is there. Ma'am, can you just unmute, please? Dr. Sandhya Sood, ma'am, if you can just please unmute and introduce Professor Beriwal.
Or maybe, sir, Barad, sir, you can maybe quickly introduce, sir.
I mean, I can introduce myself. I'm Sushil Beriwal.
Okay.
I'm one of the radiation oncologists based out of Pittsburgh. I specialize in breast, gynae, and prostate cancer. And Dr. Kunal asked me to talk about regional nodal radiation therapy in the context of Supremo trial. So I'll give you my perspective of what to do, when to do, and why to do for the so-called intermediate risk. So my talk today is on regional nodal radiation therapy for intermediate risk breast cancer. When I say intermediate risk, it's basically high risk node negative or N1 disease. That's what I'm going to focus on. Now, when we talk about regional nodal radiation therapy or post-mastectomy radiation therapy, which always involves regional nodal radiation therapy, there are two common settings. One is in the setting of lymph node dissection. The other, which is becoming more and more common, especially in the US, is sentinel lymph node biopsy, because most of these women with N1 disease nowadays do not undergo axial lymph node dissection. They only undergo sentinel lymph node biopsy. So the context and the understanding is different between the two clinical subset. When I talk about regional nodal radiation therapy as part of post-mastectomy radiation therapy for non-radiation oncologists, it means we treat undissected axilla, level 3 neck node, level 3 axillary node, medial supraclavicular node, sometimes lateral supraclavicular node, and upper IMN node. In our own practice, when we do regional nodal radiation therapy, at minimum, we treat undissected axilla, level 3 axilla, medial supraclav, and IMN. Lateral supraclav, we treat selectively. So just for you to get a context that when we talk about post-mastectomy radiation therapy, it involves chest wall and regional node. It becomes important as we talk about Supremo trial. Now, recently, ASCO came up with a clinical practice guideline this last year, talking about indication for post-mastectomy radiation therapy in upfront surgery, post-mastectomy radiation therapy after chemotherapy. It also talks about volume fractionation technique, which I will not cover because which is not important for this talk. Now, this is one of the most important slides for the entire presentation. This slide is from ASCO guideline, indication for post-mastectomy radiation therapy for upfront surgery and for neoadjuvant systemic treatment. So you can look at from upfront surgery. If you have T1, T2, N0 disease, no post-mastectomy radiation therapy unless margin is positive, which is rare. So for T1, T2, N0, no radiation therapy. For T3N0, it's conditional, and I'll talk about what it means by conditional. For T4, meaning chest wall involvement and skin involvement, we do recommend radiation therapy, but this is the intermediate risk group. For N1 disease, it says post-mastectomy radiation therapy with an asterisk because there are pros and cons of it, and which is what I'm going to discuss today. N2, N3 is advanced breast cancer. Nobody is refuting the indication of a post-mastectomy radiation therapy in that setting. And for neoadjuvant chemotherapy, again, if it is intermediate risk and if they have PCR, they talk about post-mastectomy radiation therapy conditional, and I'll talk about it why. So the intermediate risk group category would be this category, some of this category, and last but not the least, this category, which we'll talk about it. So based on the ASTRO-ASCO guideline for T2N0 disease, no post-mastectomy radiation therapy, no regional radiation therapy, unless the margin is positive, which is very rare. For T3N0 breast cancer, post-mastectomy is again conditional. In our own practice, we offer very selectively. When I say selectively, we look at other adverse factor. Other adverse factor is high genomic score, presence of LVSI, or triple negative or high-grade disease. So for most women with T3N0 disease, we favor no radiation therapy because the risk of local regional recurrence is low, and the impact of post-mastectomy radiation therapy is not seen in breast cancer mortality and survival. So just to get the context from the Supremeo trial perspective, that ASTRO-ASCO already do not recommend post-mastectomy in this subset routinely. Now, the talk which I'm going to talk about is N1, which is risk stratification, when to treat. For N2, we treat all. So that's not the context for this talk. Now, the Oxford meta-analysis, which looked at all the modern clinical trials from 1989 to 2008, covering 12,000 patients. So you have to understand, to see the impact of post-mastectomy regional nodal radiation therapy, you need large volume of patient to discern the benefit of post-mastectomy radiation therapy. But they found that the regional nodal radiation therapy reduces recurrence, decreases distant mets, and also leads to less local regional recurrence, which translates into about 2.5% improvement in breast cancer mortality at 15 years. So it takes a long time to see the improvement in breast cancer mortality. In modern clinical trial with modern chemotherapy technique and modern radiation therapy technique, adding post-mastectomy radiation therapy for N1 disease improves local regional recurrence, improves distant recurrence, which is important endpoint, which leads to reduction in breast cancer mortality. The reason why this trial, which Oxford meta-analysis showed positive impact, was because of some of the modern clinical trial. And I want to emphasize that almost all modern clinical trial, when they talk about N1 disease radiation therapy, they include regional nodal radiation therapy as part of the care. And regional nodal radiation therapy is, as I talked about, axilla, supraclav, and upper IMN. This is the Canadian study, which was in lumpectomy setting, but the idea was, what is the impact of regional nodal radiation therapy? And they did treat upper IMN node as part of the care. And you can see the absolute difference in local regional recurrence is very small, 2%, 3%. So the old paradigm, which we talk about, 4:1 ratio of every 4 recurrence translated to 1% improvement in breast cancer mortality, is all gone, because the absolute difference was very small. Absolute difference, regional recurrence was only 2%. But look at this so-called 2% difference in local regional recurrence, translated into 4% difference in distant recurrence and about 5% improvement in disease-free survival, showing that it's not the clinical regional recurrence which is important. It's a microscopic disease in the region, which could be the source for distant mets, which is important when we treat regional node. So when we talk about post-mastectomy radiation therapy, local regional recurrence is not the most important endpoint. The most important endpoint is the impact of this local regional treatment on distant mets. And that ratio in the modern era is 1:1. It's not 4:1, because of the fact that the modern systemic treatment has improved. It's the microscopic nodal disease which you're treating, which is leading to improvement in outcome. And if you look at it, the side effects were as expected. Most of them were grade 1 and grade 2, manageable without any significant impact in quality of life. The second major trial was the EORTC, which again allowed, it was similar to a Canadian study, but it had mastectomy patients also. So unlike the Canadian study, it had about 1 in 4 patients had mastectomy done. Again, the randomization was whole breast with and without regional node or post-mastectomy radiation therapy with regional node. They also treated upper IMN as part of the treatment. And you can see very, very similar numbers. You can see, look at the difference in regional recurrence, 2%. Look at the difference in local recurrence, very similar. So overall, very similar to the Canadian study, the difference in local regional recurrence was only a couple of percentage points. But if you look at disease-free survival and breast cancer mortality, very similar to Canadian study. So two independent studies done in two different continents, showing the value of regional load, showing that the absolute impact in local regional recurrence is small, maybe in the tune of 2 to 3%, but that 2 to 3% impacts distal recurrence, which is what we're talking about, 3 or 4% improvement in distal recurrence, which improves disease-free survival and breast cancer mortality. So for us to understand that when we are talking about post-mastectomy radiation therapy, our endpoint is not local regional recurrence. Our endpoint is distant mets and breast cancer mortality. Sometimes when we read this some trial and they talk about low local regional recurrence and we conclude there is no benefit of treatment, we need to understand these studies are not powered to see the difference. And plus, local regional recurrence in the modern era is small. It's the impact which has for the distant mets, which is important. And both the Canadian study and the EORTC study showed similar numbers done in same time period in two different continents. So the bone of contention or point of discussion is the Suprema trial, which came out in New England Journal of Medicine. It was presented at San Antonio Breast Conference year before last. It's a phase 3 randomized control trial. It predominantly included intermediate risk breast cancer patients. I'll show you why. But look at the intervention, chest wall versus no chest wall. They did not do regional radiation therapy, which is where the most impact comes in. The regional radiation therapy was done in a minority. So when we're reading this clinical trial, we need to understand that almost 9 out of 10 modern clinical trials for post-mastectomy or post-lumpectomy radiation therapy for node-positive disease always allowed regional node radiation therapy, which included undissected axilla, supraclavian IMN. The primary endpoint was overall survival, and it was intention to treat analysis. So you can see it had intermediate risk T1 and T2 N1 disease, T2 N0 disease, which I already talked to you about what the ASTRO-ASCO guideline says, and about 1,600 patients which were randomized to chest wall versus no chest wall, not regional node, which is one of the important drawback of this clinical trial. Majority of patients were 1 to 3 positive node, which is intermediate risk. They all got modern chemotherapy. The demographics is balanced, and median follow-up was 10 years. These are the positive part of the clinical trial. So if you look at it at 10 years median follow-up, there was no difference in overall survival. There are small difference in local regional chest wall recurrence, but that was not clinically significant. And there is no difference in disease-free survival, distant mets-free survival, and overall survival. So the trial concluded that, we don't have a value of treating post-mastectomy radiation for intermediate risk group. But I'll tell you what are the pros and cons of it. So this is the data you can see, a very small difference in chest wall recurrence and no difference in the meaningful endpoint, which is distant mets-free survival, disease-free survival, and overall survival. So let me tell you my viewpoints on it. Most of the patients who were included in the clinical trial, we don't offer routine post-mastectomy radiation therapy. We don't do post-mastectomy for T2N0 disease. We don't do post-mastectomy for micromets. You can see 25% of the patients were lymph node negative tumors where post-mastectomy is not routinely recommended. 41% had single micro or macromets. For micromets, we don't do post-mastectomy radiation therapy. Also to understand, the practice pattern has changed. For patients with 1 or 2 sentinel for biopsy positive disease, they don't undergo lymph node dissection anymore because we have multiple clinical trials which have shown dissection adds to the morbidity, lymphedema, and shoulder dysfunction, no improvement in survival, and they are usually treated with some form of radiation therapy. So in Suprema trial, all had dissection done. The practice has changed. In US, we don't do dissection in majority of these patients. The biggest flaw for the study is they were delivering radiation therapy to chest wall only. Without treating regional load, you are not doing the modern contemporary practice pattern. So many patients in the Suprema study, which were deemed to be not benefiting from post-mastectomy radiation therapy, don't even qualify for post-mastectomy radiation therapy based on the current guideline, like T2N0, T1, T2 micromets, T1, T2 macromets with full dissection with favorable subtype. So Supremo trial suggested that systemic treatment alone reduces recurrence, and we may not need post-mastectomy radiation therapy, which I agree that the type of patient which were included, they would not qualify for post-mastectomy radiation therapy in the modern era, with one important caveat that majority of these patients nowadays do not undergo dissection. So if they only have central for biopsy done and macromets, based on modern study like MRO study or Senomog study, they need some form of radiation. You can do dissection, but then you run the risk of having 20-30% risk of lymphedema, vis-a-vis less lymphedema, less impact on quality of life. So it is important to look at Supremo trial in the context of what they did and how the practice pattern has changed and how the patients who are included, majority of them are routinely not offered post-mastectomy radiation therapy. So as I mentioned, T2N0, which was part of Supremo trial, we don't treat them. T3N0, we treat very selectively, probably a minority. And then when you talk about N1 disease, where the bone of contention comes in, so to treat or not to treat N1 is based on multiple factors. Like the pro part is the MA20, the EORTC, the Danish, and the updated Oxford meta-analysis. The con part is the Supremo, which I mentioned, and the multiple modern studies showing local regional recurrence. But we need to consider the factor whether they had dissection done or not. In US, most of them don't undergo dissection because patients would rather have radiation than have risk of lymphedema. A set of patients don't want radiation, then they are offered dissection, but majority don't. Biological and status in terms of ER status, HER2 status, triple negative status, Ki67, oncotype, mamma print, those are also important. The anatomical risk factor, age, presence or absence of LVSI, extranodal extension, and optimal systemic treatment. So you take all these factors into account for N1 disease to decide whether you would offer post-mastectomy radiation therapy, not only to chest wall, but chest wall plus regional load. So this is the NCCN guideline. You can say that for patients with T1, T2, N0 disease, if they have central for biopsy positive, you can consider no further axillary surgery. And that's based on Z11, MRO, Senomog, Otosat. There are like 5 or 6 prospective randomized trials, which have shown for women with 1 or 2 positive node, if they get radiation therapy as part of the care, especially for macromets, either with whole breast or after post-mastectomy, you do not need to undergo dissection because it doesn't improve regional recurrence, it doesn't improve disease-free survival, it doesn't improve overall survival. It adds to the morbidity. The morbidity is lymphedema and shoulder dysfunction. So if you ask like people for so-called expert, you can see if you give a favorable subtype, like T1 disease, grade 1, ER positive, HER2 negative, no LVSI, no EC, which is somebody we would favor observation if they have full surgery done. You can see most people don't favor no regional radiation therapy. Some do favor treating low axilla, but again, some favor treating comprehensively, which is a minority. So you can see even in the survey across the globe, the practice pattern changes based on age of the patient, even for the favorable subtype. But majority of them don't favor regional loaded radiation therapy if everything is favorable. And that's what we do in the practice. If patient undergo dissection, we don't, but in our own practice, patient don't undergo dissection. They have macromets. Currently, we don't have any data that for macromets, we don't need to do anything. There are ongoing studies which are looking at for macromets, further axillary intervention versus no axillary intervention, including no radiation therapy. If those clinical trials show that for macromets after central for biopsy, we don't need to do anything, then probably things will scale down. But for now, we need to do something for the axilla for these patients. Now, the other important thing is just this. This is one of the most modern studies. Danish IMN2, it got published in Lancet recently. A patient got modern chemotherapy, modern radiation therapy with 3D conformal technique. The randomization, not randomization, they prospectively collected the data where right-sided were getting IMN and left-sided were not getting IMN, internal memory node. They all got regional node with and without IMN. The median follow-up is about 14 years. And you can see even with the modern systemic treatment, with modern technique, just treating IMN by itself for the right-sided breast cancer, there is significant improvement in breast cancer mortality and distant mets. And they could not identify any subset where they could skip IMN, number of node, location, nodal ratio. None of those factors were important in terms of deciding it. And the 15-year risk of ischemic heart disease or valvular heart disease with modern era was low. So again, showing that regional node is important. Even IMN nodal treatment is important. Even in the setting of modern systemic treatment, IMN has independent impact in breast cancer mortality and overall survival. And we have not identified any subset where we can skip, which was in contrast to what was done in the Supremo trial, where the regional node was not even part of the care. So that is for the N1 disease. I will just touch in brief what happens for N1, clinical N1 when they get neoadjuvant chemotherapy. And the most important study is the B51. These are N1 disease. Those who get neoadjuvant chemotherapy, they were randomized to either regional node versus no regional node if they had lumpectomy, or post-mastectomy versus no post-mastectomy if they had mastectomy done. The trial is now published. You can see for patients who had complete pathological response both in primary and the majority had a PCR in both primary and the node. There was no difference in recurrence rate with and without regional node. There is no difference in local regional recurrence, and there is no difference in any one of the endpoints. So in practice, we have scaled down. If patient really has N1 disease and has PCR both in breast and axilla, we do not routinely offer post-mastectomy radiation therapy to these patients unless there are multitude of factors and selectively. Some patients, people still do because they say it's 5 years follow-up. I have scaled down. And if they have N1 disease, confirmed on imaging pre-op, have PCR both in breast and the primary node, I skip regional node or I skip post-mastectomy radiation therapy for majority of these patients. These are the studies which I'm talking about, which talked about central for biopsy, comparing lymph node dissection with some form of radiation therapy, Amorous, Otasar, the French study, and the Senomec. And all of them showed that with and without dissection, there is no difference in disease-free survival, axillary recurrence rate, but you can see a significant increased risk of lymphedema. So in the modern era, when they have central for biopsy done, and if they have 1 or 2 node positive, they do not undergo dissection, despite 35% risk of having more nodes, no difference in regional recurrence because of some form of radiation therapy, but positive impact on quality of life with less lymphedema. For node positive micromets, I don't do anything. If they have T1, T2 disease with micromets post-mastectomy, I don't treat them. They get only systemic treatment unless they have multitude of factors, which happens in minority. But if they have mastectomy and macromets, the options are lymph node dissection or regional node. But you take patients' quality of life into account, patient choices into account. Majority of women in our own practice offer this because they want to avoid lymphedema and long-term morbidity. So even though they technically may have low to intermediate disease, but the fact that they want to avoid lymph node dissection, they end up getting some form of regional nodal radiation therapy because they have macromets and full dissection has not been done. There is an MA39 study which is looking at biomarker-based treatment for this patient, which will give us some answer. The fractionation schedule we use is 14-15, which has shown similar efficacy, acute and late effects as conventional fractionation. We routinely don't do chest wall boost unless margin is positive or patient has inflammatory breast cancer. And for lumpectomy patient, we do consider for boost. So if I have to conclude, PMRT need to include regional node radiation therapy for node positive patient, unlike Supremo trial, which did not. Currently, we offer regional nodal radiation therapy or post-mastectomy radiation therapy for all N2 disease and selective N1, unless axillary lymph node dissection is not done, then all of them get it. For node negative T2N0 or T3N0, we do very, very selectively based on adverse factor. So that is our practice pattern, my practice pattern, not necessarily the nationwide practice pattern, but supported by ASTRO-ASCO guideline. With this, I conclude. Thank you.
Thank you. Thank you very much, sir, for dissecting out the data and making things more clearer. Just one, you mentioned about genomic profiling also, and that also deciding, I think, like TAILOR-X, there is TAILOR-RT trial. So is that you are using in your practice?
So for example, like there are two situations we use it. If they have T3N0 disease, and they have high oncotype DX score, then we do consider for post-mastectomy radiation therapy for T3 and 0. For N1 disease, we do take that factor into account. And if they have dissection done, and when we decide whether to offer post-mastectomy or not, then they become high intermediate risk in my mind. But if they have central fold biopsy done, then it doesn't matter, because currently for macromets with central fold biopsy alone, we don't have any data we can skip radiation therapy or dissection. There are small subset patients where it has been done, but it's very, very small minority. So if they're macromets, they get treated for sure. But if they have macromets with dissection done, then we do take that factor into account.
Okay. One very quick comment about triple negative breast cancer. You mentioned, we all know that it is a more aggressive subtype, and thresholds for treatment are low. But in the Supremo and other trials, although the numbers were smaller, but I think they showed that those patients did worse with the radiation. Is there some concern about immune phenomena or something in TNBC?
So not in Supremo, but in B51, in like in unplanned subset analysis, they had worse outcome, but that could be a lot more variable which you don't take into account.
Right.
So what it tells us that if they have PCR, probably you don't need radiation therapy. So I don't take that adding radiation therapy had detrimental effect, because it's like an unplanned analysis of study which is not powered to see the difference between the subset. But that being said, in B51, the triple negative had worse outcome, but that could be probably a factor of disease which we don't take into account.
Yeah. So final comments from the chairperson's 20-second comments, starting with Dr. Bharat, sir, if there is anything.
Yeah, that's a nice presentation by Dr. Very well. As usual, we keep on having discussions with him during tumor board. So this is an unending, I think, debate with radiation oncologists that whether post mastectomy RT has to be given or not. Each on, and everybody has his or her own, views, whatever. But yes, just Dr. Berrywala, the one thing he has made very clear is that T3 lesions, in T3 lesions, we can omit radiotherapy, which was not being done in our center now. So T3, it can be omitted in selective cases, which with the mention, he has mentioned all the risk factor, everything. So I think we'll follow that and take care in that.
Dr. Ritu and Dr. Manjinder, very quick, if you have anything to add.
Yeah, good evening. It was an excellent presentation, and I think majority of the doubts regarding the Supremo trial and the role of post-mastectomy RT in early breast cancer has been cleared by Dr. Shashil Very. I think thanks a lot.
Thank you. Ritu ma'am, final before we move to the next session. And
Yeah, thank you, Dr. Kunal, for your invitation. And Dr. Beriwal has given a very nice presentation and cleared all the doubts about the role of radiation. And especially with modern techniques, as we can give more precise treatment. So as compared to the time when the Supremo study was evaluated. So everything has been nicely covered. Thank you, sir, for your nice presentation.
Sandhya ma'am has joined, or ma'am is there? Okay, then we move to the session by Dr. Dharampal. So we again thank Dr. Beriwal for sparing out his time. So the next session is on NHER2 for treatment of HR positive HER2 low or HR positive HER2 ultra low MBC. Over to you, Dr. Dharampal.
Good evening, everyone. Thank you, sir, for this opportunity. So I will share my slide. Sir, each slide is visible.
Yes, visible.
Okay. Thank you, sir. So I will be discuss the role of.
You can make it to the slideshow mode and it will be better.
Sure, sir. I will be discuss the role of trastuzumab deruxtecan in HER2 low, hormone positive HER2 low or ultra low metastatic breast cancer. So these are the overview. So the majority of HER2 positive, hormone positive, HER2 negative metastatic breast cancer express clinically meaningful level of HER2. So generally HER2 positive we consider IHC 3 plus or IHC 2 plus with FISH amplified. These patients contain 15 to 20% of all metastatic breast cancer, and TNBC is around 15% of total patient. Most of the patient land into low HER2, which are IHC 1 plus or IHC 2 plus with FISH negative, which is around 65%. So this is the how we see the IHC. So if weak to moderate and complete membrane staining in more than 10% of tumor cell, we consider it IHC 2 plus. And after that, we go with the FISH testing. And if faint and incomplete membrane staining in more than 10% of tumor cell, we consider it as IHC 1 plus. So this IHC 1 plus and IHC 2 plus without FISH, with FISH negative, we consider as a HER2 low, which is around 60 to 65% of total patient. HER2 ultra low mean faint incomplete membrane staining in less than 10% of tumor cell with IHC. So it is contain 20 to 25% of the total patient. So this is the what is the need of this trial? That as of current treatment is for hormone positive MBC is endocrine therapy and CDK4/6 inhibitor. So with that we achieve progression free survival is around 24 to 28 months. If patient progress on this, then we generally consider second line with another endocrine therapy, with target therapy or another single agent monotherapy. For which we can reach PFS with 5.5 month or 2 to 2.6 months. In third line setting, generally we use single agent chemotherapy or from which chemotherapy we can achieve PFS of 6 to 7 months. But if we use TDXD in that setting, so this is come out 10.1 month with TDXD. So this is the need of use of TDXD in hormone positive setting. So we all know this is the TDXD. This is antibody drug conjugate. It contains monoclonal antibody as well as drug which is isomerase topoisomerase 1 inhibitor, and it is also so that this is also so a effect bystander antitumor effect. So after release in the membrane permeable payload result in killing of the neighbor cell. So this is the background. So in so I will discuss briefly. So Destiny Breast 06 trial. It was an open label randomized multi-center phase 3 study. So they have taken hormone positive MBC who have the patient who have not taken any chemotherapy before, at least received two or more than two line of endocrine therapy, either receive patient was on adjuvant chemotherapy but progress on within 24 months, or patient was on endocrine therapy plus CDK4/6 and progression within 6 months. So they have randomized into trastuzumab deruxtecan 5.4 milligram per kg 3 weekly, and this therapy of physician choice capecitabine, nab-paclitaxel, whatever. So primary endpoint was PFS in the HER2 low as per the this committee, and the secondary endpoint was PFS in the interim to treat population, overall survival in HER2 low and overall survival in interim ITT. There was other secondary endpoint PFS HER2 low, PFS2. So this is the result of the trial. So with the use of TDXD, the PFS was 13.2 month, and with the use of chemotherapy, it was 5.1 month. So there is this so benefit of 5.1 month is there. TDXD demonstrated statistically significant and clinically meaningful improvement in PFS compared with standard of care chemotherapy in HER2 low. So this is the same result seen in the interim to treat population with the delta of 5.1 month. So this is the OS in HER2 low. in ITT. So it is around with TDXD, a 12-month OS rate with chemotherapy, it was 81%, and with TDXD, it was 87%. So 20.1% of the patient in the chemotherapy received TDXD post-treatment discontinuation. And this result was similar in the interim to treat population with a hazard ratio of 0.81. So these are the subgroup analysis. So this consistent benefit of PFS was consistent with all subgroup, irrespective of age, previous CDK4/6 inhibitor, HER2 expression. So the benefit was seen in favor of TDXD in all subgroup. So this is the PFS and OS in HER2 ultra low pre-specified extrapolatory analysis. PFS was in TDXD, it was 13.2 month, and chemotherapy it was 8.3 month with benefit of 4.9 month. And OS was 12-month OS rate in chemotherapy was 78%, and in TDXD it was 84%. So PFS improvement with TDXD versus TPSC in HER2 ultra low was consistent with result in HER2 low. So it was consistent in HER2 low and ultra low. So this is the PFS2 in the overall ITT population and time to progression subgroup with hazard. So benefit of 5.6 months. So delay in PFS2 was clinically meaningful in favor of TDXD in the interim to treat population and TTP subgroup. So they have also observed the benefit of progression-free survival with the measure of disease burden. They have this was the subgroup analysis. They have taken less than 3 and local metastatic site at baseline, which show benefit of 6.9 months, and more than 3 and local or metastatic sites show benefit of 4.2 months. So PFS benefit with TDHD was observed regardless of disease burden with notable efficacy in patient with lower disease burden. So this is the safety. So as we know, all that the most common, the specific side effect for trastuzumab deruxtecan is the pneumonitis, which was seen in 5.3%, and the in chemotherapy 1.4% show peripheral sensory neuropathy. Most common treatment related adverse associated with the dose reduction was nausea in the TDHD, it was 4.4%, and in chemotherapy it was 16.5%. So, adverse event of special interest. So, median time to onset of educated ILD pneumonitis in the TDXD arm was 141 days. Of the 49 patients with any grade adjudicated ILD in the TDXD arm, 20 were reported as having recovered, 2 were reported as recovered, and sequelae 3 were reported as recovering at DCO. So, this is the analysis of quality of life. In order to maintain overall health, quality related quality of life and functioning versus chemotherapy in patient with a HER2 positive, HER2 low, and HER2 ultra low MBC. So this was the graph which showing the baseline GSS score was at 69.51 with TDXD with chemotherapy is 65.1. So this is the quality of life score. So this is the conclusion. Destiny Breast 6 established TDXD as an effective new treatment option for patient with patient with HER2 positive, hormone positive, HER2 low, and HER2 ultra low MBC following one or more than one endocrine based therapy with PFS benefit of around 5 to 6 months, and in ITT it's same 4 to 5 months. So this is the again same. So secondary endpoint was overall response, which is 56.5% with NHER2 and 32.2% with chemotherapy. So this is the ESMO guideline current recommendation 2025. If patient is base hormone positive, HER2 negative, not received any chemotherapy and progress on endocrine therapy, and HER2 is low or ultra low, we can consider trastuzumab deruxtecan. This is the NCCN guideline for 2025, suggestive same. Thank you, sir.
Thank you, Dr. Dharampal. So have you used TDXD in this setting? Has you had a chance, you have had a chance to use?
No, sir. In such setting, I have not used in hormone positive progress on. I have not used, sir.
Okay.
We are using only second line.
With time and maybe cost
Yes, sir. Cost
including
is the main issue.
possibly. Okay, thank you. So we'll move to the next session, panel discussion, and I'd request uh, one of the senior consultants, medical oncologists of this region, Dr. Jatin Sareen, to kindly invite his panelists and moderate the session. Sir, on HER2 positive early breast cancer.
Thank you, Kunal, for inviting me for this session, and hope you'll facilitate me if I finish this session before time. Let me share my slides, and before that, let me invite my panelists. Dr. Anuj Bansal.
Hello, Dr. Jatin.
Hello, Anuj, senior medical oncologist from Batinda. Dr. Dharampal Jakar, we just heard a presentation from Dr. Jakar. Dr. Kanwar Neet Singh, a good friend from and surgical oncologist from Patiala. Kanwar,
Good evening, sir.
good
How are you,
evening.
sir?
How are you?
Uh,
Dr. Yeah. So Dr. Amrit Jot Singh Randhawa.
Yes, sir. Good evening, sir.
Good evening. Good evening. Good evening. And Dr. Sumit Jain
Yeah.
from Ludhiana.
Good evening, sir.
Oh, so everybody is there. Okay. Uh, so Kunal, can we have the luxury of including you also in the session and have some pearls from your wisdom?
Yes, sir, I'll be the timekeeper. I have to
Yeah.
facilitate you, so I'll be the
No,
timekeeper.
we'll be requesting some interesting comments also. Uh, so should I share the slides or okay? Uh, so my slides are visible.
Yes, sir.
Yeah. So I think we had a very good presentation right at the beginning of this meet from Dr. Akansha about the usage of anti-HER2 agents in early breast cancer. So this session is these slides are provided to me by Roche, and these are my disclaimers. So let's straight away go to the case history. Sorry, I'm slightly under the weather. So this is a 45-year-old premenopausal woman which presents with a mass in left breast, which she first noticed 2 months ago. And over the last 2 weeks, the mass has become painful, and she doesn't have any comorbidity and also doesn't have any family history. The physical examination revealed a 3 centimeter mildly tender mass in left breast with no overlying skin or nipple skin changes or nipple discharge. And there was a firm and large palpable lymph node in the left axilla. So that makes things easy. The rest of the examination is within normal limits. So the diagnostic test, as we all usually do, first there is a mammogram and sometimes even ultrasound sonomammogram, and it revealed a 4 centimeter tumor, and there was a ipsilateral enlarged axillary lymph node, and the biopsy revealed it to be invasive duct carcinoma, poorly differentiated, so it was a high grade one with estrogen receptor positivity and HER2 receptor positivity by IHC. And FNAC of axillary node was also positive. So it was a newly diagnosed, clinically stage 2B, HER2 positive, hormone receptor positive breast cancer. So, first question to Anuj. So how would you approach this case? How do you manage this case? Uh, Suppose this case lands up with you.
You have done biopsy, I think biopsy with the this thing HER2 status, ERPS status we have. Staging workup, I think we need to do for this patient. That may include X-ray and ultrasound, or some people do CT scan as well, or sometimes PET scan. For some patients, we do PET scan also. And completing staging after that, I think nowadays we may get BRCA1, BRCA2 testing for these patients, and then we can go for neoadjuvant chemotherapy in this case,
Do,
because
do
it is
we
a
do
more
we
costly.
do BRCA testing in HER2 positive?
Yes, preferably I think for all breast cancer patients we should do BRCA testing.
Okay. Uh, so then, finally, it is stage 2B. So how will you approach that treatment?
For this patient as node positive disease, I'll go for neoadjuvant chemotherapy,
Hmm.
HER2 directed dual HER2 therapy,
Hmm.
with the most likely anthracycline free, because nowadays we know that there's no added advantage of giving anthracycline. So docetaxel with carboplatin with trastuzumab and pertuzumab.
So you
6 cycles.
a lot many unanswered questions also. Anyways, so the question to the surgeons in this panel. Suppose this patient with this particular stage lands up with you, and after biopsy it is HER2 positive, and this one is also hormone receptor positive. What will be your way to go, Kamalneet?
But it would always be the case for a medical oncologist once it's a HER2 positive disease.
Yeah.
So it never is our decision to make when to do surgery.
Hmm.
Once it's triple negative or HER2 positive disease, it's always the case for the medical oncologist to decide the regimen, how to go about it, and to make a
Hmm.
plan for the patient. So
Hmm.
anyway, it's a HER2 positive disease, I would take a consultation for the medical oncologist, and mostly these patients would go for a neoadjuvant treatment.
So let me ask the other way. Any HER2 positive disease you will operate upfront?
Maybe sort of very small tumor, a T1N0 patient, an old patient, maybe, but mostly HER2 positive thing just rings a bell, and nowadays would be sent for a medical oncology opinion before surgery.
The two things. First is ideal world scenario. Yes, you give dual HER2 blockade, but you should look at the financial aspect. If the patient is actually affording pertuzumab or is actually affording TDM1, I
Hmm.
think if the patient upfront says he can't afford these expensive therapies,
Hmm.
there may be a scenario in early breast cancer you can offer surgery in a HER2 in a ERPR hormone positive tumor. But rest of the scenarios, yes, ideally you need to get a dual HER2 blockade.
No, no, no. If the patient is affording only trastuzumab, then also will you go for upfront surgery? If suppose even in early breast cancer you have a node positive, clear-cut node positive beforehand.
Single N1 disease, maybe yes, sir, because the treatment is not going to change. If you look at the treatment, it is going to be whether you do upfront surgery or you do after neoadjuvant therapy, the treatment remains the same. The cycles remain the same. The treatment will absolutely nothing will change in the treatment of the patient.
Okay,
So
so
these
this
are
is
the
To add
scenarios.
one thing,
practical points you are.
we can, if we do neoadjuvant chemotherapy, we
Hmm.
can accelerate therapy post surgery. If there's a residual disease, we can
So
accelerate
you're
the therapy.
saying in a scenario when the patient cannot afford TDM1, which actually happens in some cases. Yes,
Yeah,
very good.
routinely everyone knows what we do, but for I think theoretical purposes,
Yeah.
we should
No, no,
discuss.
Theoretical is yes.
we know about the theoretical aspect. We have heard very good presentation, and we know what is the standard of care and all the stuff. But here I had asked a question which is more of a day-to-day practice question. So yes, ideally, all patients of HER2 positive, all eligible patients of HER2 positive should receive neoadjuvant therapy with dual HER2 blockade, preferably. But in the practical scenario, I asked my surgeons that what do you do or in what scenarios do you do upfront surgeries? Yes, there are, just wanted to understand, there are a lot many patients who are still undergoing upfront surgery. Anyways, so so how do you define patient at high risk of recurrence? Dharampal, uh,
Uh,
what factors do you keep in mind in a if the patient is HER2 positive? Suppose this patient was poorly differentiated, ER positive, HER2 positive. So
uh,
is he a high risk patient, or
Yeah,
does?
sir, as you see, this patient is high risk. The first thing is the age, sir, 45 years. So this is young patient. Young
Right.
age is high risk. Second is
Perfect.
the, sir, the history of patient is saying the mass is from the 2 week to symptomatic for 2 week, and mass is palpable since 2 months. So there is a history of only 2 months. This is also saying that this is bad biology disease.
Okay.
HER2 positive disease itself, it's a bad biology. So this patient is young patient, short history of lump and HER2 positive, and we know this is no. So there is a
So my question is, what clinico-pathological factors do you take in consideration when you say that this patient is a high-risk case
sir.
and
Sir, the first thing is the hormone status. If TNBC is high risk of recurrence. The second thing is age. If patient is young age, we consider is high risk. Third, generally in BRCA status, if patient is BRCA positive, it's high risk.
hmm,
And fourth, sir, tumor on based on tumor size and nodal disease. If T4 and 2 disease, it's uh, higher the T, higher the N is higher risk of the recurrence. As per guidelines, sir, we generally do BRCA testing in all TNBC and all rest of the patient less than 60 years.
less than 60 years, all the
Yes.
patients.
Less than 60 year all the patient and TNBC irrespective of age, sir.
Okay. Um, that's okay. I mean, I'm not asking about the genetic part as yet. That has more relevance I feel, in hormone receptor positive and TNBC. So, Anuj, do you think with these parameter, with the current clinico-pathological parameters, we are able to identify most of the patient with high risk of recurrence?
Yeah, most of the patient we can find out with the pathological features, clinical and pathological features,
Mm,
as Dr. Dharampal has mentioned. Some points are missing. I think one is Ki-67.
mm,
If it is very high, definitely it goes in favor of high risk. And then
mm,
grade 3 tumors, lymphovascular invasions.
mm.
So these features are also in favor of high risk.
Yeah. So, any one of you have heard about HER2 DX scoring?
Yes, we have heard, but not in practice.
Not in
We are not
practice.
doing it. We are not doing it.
Okay. So we'll come to that later. So suppose it's a borderline risk of recurrence. So do you prefer giving NACT even with borderline risk of recurrence? Suppose early HER2 positive tumors, let's say node negative T2 tumor.
Node negative T2 tumor, I'll go with the trastuzumab alone with chemotherapy.
Okay. And suppose it is T2N1, like.
Then definitely, if node positive, then I'll prefer dual therapy.
So these are the various parameters in which we say the tumors are high risk. People have started looking at even TILs these days. Low levels of TILs are also high risk tumor, but I think they don't have a very good response to systemic treatments also. But anyways, and in this HR positive is considered a high risk tumor also. And yes, I think my panelists have listed most of the things. I think the grade of the tumor is not mentioned. I think with Ki-67 and great, I think.
And it's a hormone positive or tumors are high risk or hormone negative?
So, if you consider the response to the treatment, systemic treatment, then hormone negative respond well. In a HER2 positive case,
But
I'm
overall
talking.
prognosis wise, I think hormone positive are better.
We'll come to that later. We'll come to that later because hormone positive, HER2 positive, they're not so good as compared to hormone positive alone. So, anyways, uh, so how would you treat this? As we have already discussed, neoadjuvant treatment dual HER2 blockade is the suppose Anuj, this patient is not able to afford pertuzumab. So, what would be your go-to regime in this particular patient?
Then I'll go with TCH regime,
Okay.
docetaxel carboplatin with trastuzumab. But
So,
pertuzumab now generic is available and they are giving at a very good price.
okay. No, suppose the patient is not able to take even a generic pertuzumab.
That's fine. So go to
Then
TCH.
TCH.
TCH 6 cycles
So,
and
would
then
you
go to
be tempted to use Anthra in that case?
no, at present I'm not using anthracycline
Mm-hmm.
because of high toxicity, more neutropenia and cardiotoxicity and some more risk.
So, Anuj, since how long have been using TCH?
Maybe around 6 7 years.
Okay, and before that?
Before that, I think whenever I started adding trastuzumab, I started with TCH only. Very few patients I've used. It's not that I've not used AC followed by TCH, but some patients I have, very few patients, you can say maybe 5% patients I have given anthracycline as well.
I think people are omitting Anthra in the era of dual HER2 blockade. If Dr. Dharampal, what do you do?
Sir, generally, definitely in node positive disease, we start with a dual HER2 targeted therapy and
Hmm.
preferred. So in this case, we can go ahead with the TCHP, a 6 cycle of TCHP followed by
That's
surgery.
perfect.
But
I'll tell, let's say patient is not able to take pertuzumab, even generic pertuzumab.
sir, in so our guideline is so our institutional protocol in HER2 targeted, we always start with the trastuzumab. So if patient is not affordable, we start with the paclitaxel trastuzumab, and after 4 cycle and after surgery, we see the disease burden. If after 4P plus H there is no PET-CR and still nodal disease burden is there, suppose there is N2 disease,
Hmm.
after the surgery, we'll consider a anthracycline based regime, sir.
So, okay, so you're tailoring the treatment already. Wow. So this is actually a part of a trial. Kunal, I would like to have your comments out here if you can help me out. So, have you also?
Somebody is unable to afford, but what I understand is that HER2 positive disease, high risk, we are planning neoadjuvant and patient is unable to afford pertuzumab.
Yeah.
Is the setting. And especially if the patient is HR positive, which is this case, I would be tempted to use anthracycline in that case. AC4 followed. I will complete all neoadjuvant chemo beforehand. Put in a clip, which I think somebody, I don't know, mentioned or not mentioned. If breast conserving surgery is planned, I think that is also important. That early breast cancer patient should have a clipping done. And after 4 cycles anthracycline, give them 4 cycles of trastuzumab with the taxane, preferably docetaxel, and then consider for assessment and surgery.
So even I haven't omitted anthracyclines in my this thing in patients who don't afford pertuzumab because it's not that.
I don't
Uh,
think there is any data that says that AC followed by docetaxel trastuzumab is better than TCH or
is there any?
data which suggests that adding anthracycline, if we are not giving pertuzumab, gives
Yeah.
better
Yeah.
result.
If you are asking for the PCR, I think the PCR differs with 6 cycles of DCH versus AC and TH.
I don't know.
If you think that PCR, which we all think that PCR is
Yeah.
the holy grail
Correct.
for survival of HER2 positive disease.
Fair.
If we look at the train to trial and omit pertuzumab anyway and look at only the anthracycline trastuzumab, that
Uh,
regimen we are not following. The type of regimen they were using in train 2 is not,
yeah.
nobody uses that dose.
Nobody
That type of
uses.
doses.
Nobody
That
uses.
So I
So
think
the thing is, if someone can afford dual HER2,
yes,
then perfectly you can safely omit anthracyclines. I am not saying that you cannot. But
the
on the other side, if someone is not, then I would, if the patient is fit enough as this patient, like premenopausal with no comorbidities, then I would use anthracycline. I'm not going to forego anthracycline, and especially in HR positive.
equivalence of TCH has been mainly in the adjuvant setting in the BCI
Yeah,
G006
that
trial.
it is more in adjuvant setting. It is not never in a new adjuvant setting. So, anyways, this is just part of discussion only. So anthracycline versus no anthracycline, we had a very open debate just now. So yes, the PCR rates are good enough if we use dual HER2 blockade without anthracycline. They are very good. There's no issue altogether. And with the advent of generics, yes, more and more patients are being put on dual HER2 along with the Taxane and Platin. And that is what the guidelines are also saying. And I don't want to go into the details of these guidelines. So, suppose we want to use dual HER2. So, Anuj, do you use mainly IV formulations or you go for subcutaneous formulation like Fesgo?
Very few patients I've given Fesgo.
Okay.
Mainly, whatever I've given, it's more of IV.
Okay. So it's mainly the cost,
Cost factor, yeah,
cost,
definitely.
definitely. So, okay. But whenever the Fesgo has been used, don't you feel it is more
Yeah, it
convenient?
is easier and I think very comfortable for the patient as well as for clinician if we prefer Fesgo.
If you prefer Fesgo, right? So even when the cheaper generics are available, which are recently the generics have brought down the cost drastically. Uh, 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 Before this, when we use the generic Pertuzu and Trastu, then also you preferred IV as compared to Fesgo.
That time I've not used pertuzumab. When generic came, then only I started because the financial issues were there. So now
Okay,
I've started.
okay, okay. So,
Before that, two, three patients were there. Those have received Fesgo only.
okay, okay. So, the only thing is with the usage of since it has to be used for long and dual anti-HER2 agents, and sometimes with TCHP we use usually weekly Paclitaxel with instead of docetaxel. The reason best known is that sometimes the diarrhea is very troublesome with the usage of dual HER2 along with docetaxel. So we need indwelling venous access many times. But if you are using Fesgo, one is the requirement of indwelling venous access is less. And yes, in busy daycares, which most of us don't have, so we don't have much of a problem. But yes, uh, Fesgo, can be given easily, and there can be resource saving. And yes, we are giving a good quantity of medicine in a proper way through FESGO, not to demean the intravenous pertuzumab or trastuzumab. So it's more of a convenience part. That FESGO is a very good this thing formulation. So the difference is that we have a fixed dose of pertuzumab and trastuzumab in subcutaneous formulation, and it also contains the recombinant human hyaluronidase, which allows the kind of volume that we have to give subcutaneous. And yes, obviously it saves a lot of daycare time. And the pharmacokinetics are non-inferior, rather sometimes even superior. So again, it's the same thing. The convenient part with the FESGO is there as compared to intravenous administration of dual anti-HER2 agents. And so this was a phase 3B study conducted in Spain, which was basically to see that how much of the time was saved both for the patient and the caregivers with FESGO versus intravenous. And the secondary objective was the safety and tolerability and resource utilization. And yes, it fared well in both the primary as well as secondary objective. And the summary of this study was there was a significant time savings. Use of several medical consumables were reduced with FESGO, and their study treatments were well tolerated. So I have used FESGO in lot many patients, and in both the early and metastatic breast cancer patient. Definitely the convenient quotient is more as compared to the intravenous administration. Definitely, there is a convenient quotient, and people come, sometimes they come alone. The ladies come alone and just take the medicine, and they are off to their home within 15 minutes or so. So that is the good thing about FESGO. And with the kind of, I think, patient assistance available, there are many of my early as well as and metastatic breast cancer patients. They are on FESGO and they are benefiting wonderfully. I think they would benefit with the intravenous administration also. But if you see the efficacy part, yes, it is not inferior, and convenient part, it is far superior. So, any view, any opinion, anybody? Dr. Amrinder hasn't spoken. Dr.
Yes,
Amrinder?
yes, sir. So I have used FESGO. It's quite convenient to use.
Hmm.
Uh,
Uh,
but
So,
the only problem is with the financial part.
only problem with the financial part. So, okay. So a recent white paper showed a real world value of switching to FESGO for patients in HCP. I won't go into much of the detail. Let's go into the rest of the things. Uh, so this particular patient received neoadjuvant treatment, and dosi, carb, and FESGO, and the patient completed 6 cycles. She tolerated treatment well, grade 2 mucositis beginning with the third cycles, which was managed. And the and she achieved PCR. So, Anuj, how many of HR positive, HER2 positive patient do you feel achieve PCR with dual HER2 blockade?
I
In your
think
practice, just roughly, rough estimate.
my I can't tell my experience because not much used much dual therapy, but I think 45-50% path CR is there with the dual therapy, and the single agent trastuzumab it is around 25 to 30%.
Okay. So, I'm asking, does it matter if it is HR positive or HR negative?
Yes, if it is hormone positive, then path CR rates are less, but
Yes.
overall prognosis are better in those cases, even if there is a residual disease.
Okay.
Yeah.
So, here we discuss about HER2-DX, and HER2-DX is a score. We all have heard about Oncotype DX in hormone receptor positive cancers. HER2-DX is a score, a genomic score, or genomic test done in all the breast cancers. One can do that, and there is a good amount or fair amount of correlation between the clinico-pathological parameters and HER2-DX, risk of recurrence scores, likelihood of PCR, as well as benefit from the anti-HER2 therapy in a patient concerned. So there are very good articles, especially from the Spanish oncology, about the HER2-DX score, and maybe in future, like we are going to tailor the therapy of a HER2 positive patient, maybe adding new adjuvant as Dr. Akansha discussed, new adjuvant hormone plus anti-HER2, or scale down the dual HER2 thing, use TDM1 instead of or single trastuzumab, or reduce the number of cycles, chemotherapy cycles. All these things we can more objectively assess when we start this using this score, this particular score in a routine setting.
Any
So
idea
what?
about the cost of this test? I don't know.
No, no idea, no idea. No. We are at present discussing only on this academic forum. The thing is, even I came to know about these things recently. So I don't have any idea what is the cost of this test as yet. But what I have read about it is these things, that this particular genomic scores gives data on the immune response, on the luminal differentiation, on the HER2 expression, and on the tumor cell proliferation. And integrating all these four parameters, they give a score. One is the relapse risk score, other is the PCR likelihood scores, and other is the ERBB2 or HER2 mRNA scores, which is actually the measure of the HER2 positivity in a particular tumor. This is the real objective measure. The subjectivity is absolutely gone in this. And all these scores are being given from 1 to 99, and you see these different colors, light blue, dark blue, and there is some intermediate blue. So these are risk stratifications starting from 1 to 99. So relapse risk score high comes somewhere here, when the on some point scale, high chance of PCR come somewhere here, and same way ERBB2 mRNA expression. There has been a good amount of clinico-pathological correlation with HER2-DX score. So there have been studies in the West in which it has been shown that, and there are evidence-based clinical consideration guided by HER2-DX results have been done, and it has been shown that in HER2-DX low risk, you can safely use single agent trastuzumab or TDM1 versus the HER2-DX high risk score, in which you have to use multi-agent chemotherapy with dual HER2 blockade. And in similar fashion, sometimes if you feel that what to achieve a high PCR, if whether dual HER2 blockade is actually required as
Sorry
com
to interrupt, sir. Kindly
yeah,
conclude.
yeah. So this was the newer additional thing. I think one can review all these things, and I may forward you the paper if anybody is interested. And a dual HER2 blocker shows higher response for medium and high risk HER2-DX signature. This has been shown. So after that, the affinity study, suppose you have achieved PCR, would you continue dual HER2 blockade? Dharampal, if you have achieved PCR, would you continue dual HER2 blockade at
Yes,
June?
sir. If we started with dual HER2 targeted with node positive disease, we'll
Hmm.
continue with the dual HER2 targeted, sir.
If you have achieved PCR.
Yes, sir.
Okay. And in node negative?
In node negative, sir, so generally if we started, there is PHCR, so we will continue with the same HER2 targeted therapy, whichever we use in a new adjuvant setting.
Suppose you have used dual HER2 and you have achieved path CR in node negative.
T2 node
T3,
negative.
T3 and 0.
Sir, T3N0 node negative, if we achieve PHCR, we'll continue with dual HER2 targeted therapy.
I think for node negative, we may continue with a single agent if it is a node negative to begin with,
Hmm.
and there is a path CR, and
Hmm.
if it is node positive, then we need to give dual therapy.
Hmm. So the lot has been discussed about affinity data, that now there has been 11.3 years follow-up data in which there was an absolute delta of around 3.4% in IDFS rate. So one can make their own conclusion, but I would agree with everyone that in node positive achieving path CR, I would, if the patient can take, I would always continue with dual HER2. So the same thing. Mm, So thank you. And any comments? Kunal, I consider you the chairperson, so comments from you.
Thank you for moderation, excellent moderation in this setting. I'll just take a step back and also say that we are talking about ideal scenario, but not all our patients undergo even biopsy for before surgery. So I think that is where we have to, I think first we have to do the right things first and do the biopsy for all. Then only we will come to know the ERPR HER2 status, and then we can make a better judgment. But yes, I think in the ideal setting, this is what it should be. Dr. Satyankar had posted a question in the chat box about sites of administration of FESGO, and Dr. Vaswani, Bharat Vaswani, who will be the next speaker, has already answered. I think the approved sites are only the thigh, which have to be alternated between right and left, and you rotate in the thigh area. But I am not aware if anybody has anything to mention about that. Uh, Please
Kunal
do.
sir, actually, I am currently having two young females, and they always object having, in the sites they are very inconvenient to. So that is why I asked
So,
question.
Kunal, I've been using Fesgo in both young as well as old females. And by rotation, I've been using in alternate thighs, and till date, thankfully, touch wood, I haven't experienced much of a difficulty, or no female has actually complained about the or any issue as far as thigh.
I think it is important to counsel the patients upfront, and if there is any reservation about administration, I think the way to go is IV pertuzumab, where we have an option.
Yeah. Thank
Thank you. Thank you, sir. Thank you, all the panelists also. Thank you very much. And over to Dr. Bharat Vaswani. We are eagerly waiting for your kind of a summary of SABCS. So take us to San Antonio.
Yeah.
Right.
Hi, thanks, Kunal. Are my slides visible?
Yes, visible.
And am I audible clearly?
Yes, sir.
So first, let me thank Kunal for the kind invitation. Thank Tarun also for giving me a chance. Actually, this is the best job I do. I reviewed ESMO, and then I reviewed this SABCS, and in fact, there were so many presentations which were continuation of this ESMO only. If I tell you there were 3 phase 3 original data, others were continuation. Out of it, 2 are maybe are practice changing. So if I summarize it, there were 3 phase 3 data. One was HER2 climb 05. Second was a lid era study. And third was the Ascent 7 study. So Ascent 7 was, I have not covered it because it was a negative study. In a hormone receptor positive, taken first line hormonal and then comparing it with chemotherapy, which was not statistically significant. So sacituzumab post first line hormonal when compared with standard of care chemo did not show any importance. So I did not clear. Now there are 4 subsets of patient where you should, which was important. The first, as I told you, third was, suppose if I have given my patient, as most of us give now, in a first line hormone receptor positive, HER2 negative metastatic breast cancer, CDK4/6 with the AI, what should be the best second line treatment? So there was a detailed discussion in the.
Bharat, your slides are not moving.
No, I have not started, sir. 1 minute.
Okay.
So that is why, and there was 2. So, and the last was adjuvant carboplatin. I'm not talking about neoadjuvant. I'm talking about adjuvant carboplatin in TNBC. So 2 phase 3 data which are positive. So now the debate will start here. So let me start with the first study, HER2 climb 05 study. Now basically post first line chemotherapy with Cleopatra. Remember your Cleopatra, taxanes, Herceptin, pertuzumab. 6 to 8 cycle. What is the ideal maintenance treatment? If you remember your last SABCS, there was a Patina study which showed that giving palbo with letro along with pertuzumab, trastuzumab, there was a PFS was 44 months, which has not been achieved even by Destiny 09 study. So this study basically looked at, suppose if I use tucatinib with trastuzumab and pertuzumab, what will be my PFS and is it advantage? And this is clinically relevant for us in a ER negative subset. So HER2 climb tucatinib plus HP versus HP only as a maintenance therapy post thing. So post Cleopatra 6 cycles. So if you look into it, no evidence of progression after THP. And there was this study, basically, this is the first study which allowed asymptomatic brain mets also. As you know, tucatinib worked well. First line, if you see, the chemotherapy worked very well. 69% were de novo, 30% was relapse. ORR with TCHP was, or THP was 72 with a CR of 9. Use tucatinib with HP versus placebo and bow. Now, important part of this study was it was a non-crossover study. If you see Ascent trial, they are all crossover. So probably we'll get a OS also being a non-crossover study. The primary endpoints was investigated assess PFS. One peculiar thing was the CNS PFS was mentioned, which I think was good. Now, when you look into it, 12% had de novo brain mets, which was asymptomatic, non-progressive. There, the quantum was also there, where they checked this 9 weekly MRI as against 6 monthly MRI for a non-brain mets patient. So, investigation assess PSF. So, this quantum of benefit was 8.6 months absolute gain in progression-free survival. Please remember 16, this is already, we know that it is okay, 24.9, but you can't compare with Petina, which was 43 per yes. As against only HP, tucatinib added another 8.6 months more of PFS, which was statistically significant, nearly 36% reduction in the risk of progression. All groups, irrespective of hormone status or response to whether it was partial to THP, benefited. When you looked into blinded independent central review, this quantum of benefit was more. In fact, 12.9 months. But yes, a PFS was investigator. So we remember 8.6 months. Now, the most important slide. What about hormone receptor negative versus positive? So the quantum of benefit with hormone receptor negative was 12.3 versus 8.6 months and 45% reduction as against 36. So a better thing as against hormone receptor positive, where it was 6.9. Please remember, half of these patients took even hormone also, which I think is not good. You need to give 100% if they are ER positive hormonal therapy. And probably if I have been given a chance, I'll use Latro plus Palbo with HP rather than this in a hormone negative. But a thumbs up, a big thumbs up for a hormone receptor negative, which I think this will be the standard of care when you see, because this adds 12 months to your PFS. And probably not much for hormone receptor positive. The side effect profile was same, diarrhea and LFT abnormality, and there was no increased patients for discontinuation. So my thoughts for the first study, that is HER2 05, is, are these results practice changing? A big yes. Toxicity manageable. On a Monday morning, where should you start giving this regime on a morning? So that should be in a ER negative subset. In a ER positive, I'll follow Petina study. Now, all of us know two big superstars long term, and there are many also. That is, but after 20 years, we have a new superstar in the adjuvant setting. Remember your tamoxifen AI, and that new superstar is giredestrant, which is a SERD. So probably this should be the most talking point about a new drug in the adjuvant setting. So what is giredestrant? So it is a selective estrogen receptor antagonist. That is what we say, estrogen receptor antagonist plus a degrader also. So a biphasic activity. We have a data of giredestrant in neoadjuvant, which was better. We have a data in the metastatic, but for the first data, adjuvant setting. So giredestrant versus standard of care as adjuvant therapy for ER positive, a phase 3 big study, LID-ERA study. So ERA is estrogen receptor antagonist, ID stands for invasive disease. So probably these were not all patients, but if you say natal patient, so T more than 1 centimeter with grade 3 or KI20 section more than 20, or a high genomic score or node positive. Please remember, only 2% were ER low, so less than 10. So probably in less than 10, probably how much it is advantage, we don't know. Giredestrant 4,170 versus standard of care, which was either a AI or a tamoxifen. 40% were premenopausal, 16% had used tamoxifen, and the long-term data was IDFS. Around these were mostly high risk because 80% had taken chemo, 46% N1 and 33% N2 to NT. Now, when you look into the subset, if you see these were the two subset and it is natal or MUNAR. So 70% was like MUNAR, so a bit higher subset. So probably in this subset, I think when the drug is available and when will be cost basically lesser, we might use it. Now comes to the primary endpoint. IDFS at the end of 3 years, an absolute gain of 2.5% from 89.6 to 92.4. There was a 30% reduction in the risk of progression, and it was statistically significant. Please remember, at 3 years, we have got the difference, and I think so this difference will increase as the duration of the treatment increases. What was bit was that tamoxifen, the IIM did well, but tamoxifen, there was a more difference. And that is why what we say is, if we would have added a OFS with tamoxifen, probably this 2.5 might have come down. Because if you say with AI with this, it was a bit lesser. So although it was beneficial, but a bit apprehension, but a big thumbs up. So now, is it a standard of care? The answer is no. because we have a monarchy and a natal data which says that we should use a CDK4/6 with the AI. So my thing is, can I avoid giving a CDK4/6 and give, suppose if this giredestrant is available, should I give it? The answer is no. Now, when you look into the 3 years IDFS for natal, it was 87, but the difference was 2.7%. But when you look into monarch, the difference was 5% difference between the other arm, which is twice the benefit what we got it with giredestrant. So if I have been given a chance, I would use a CDK4/6 with this. And future will tell us, remember the data that you have with EMBER-3, Abima with with imlunestrant, probably that is a way to go in future, that giredestrant with a CDK4/6 in a very high risk, it could be probably the thing. Now, does it benefit in medium and high risk? The answer is yes. And these differences are likely to improve over longer follow-up and more event. Toxicity for me, the simplest drug with some myalgia, some bradycardia, and some venous episode is there. But again, the discontinuation is negligible, probably a better or a more safer drug maybe as compared to AI. So it will be a big thumbs up when it comes. So what is my thoughts? Is the trial practice changing? Yes. For those patients taking hormone treatment only. Can it replace standard of care, that is AI plus CDK4/6? The answer is no. At least for Abima, the benefit at 3 was twice. Future will look at giredestrant with CDK4/6, which I am very excited about. As I'll be telling you in my third part, this is the way the second line treatment is going. And at present, I don't think so the finances will allow any of us to take this treatment. If you are high risk, I think AI with CDK4/6. But yes, there is a drug which in a single agent is better than an AI at a small follow-up for 3 years. So the question is, I don't know what will be the future of this. The third section deals with 2 trials, which was a follow-up study. And probably if I have given my CDK4/6 with the AI in the first line, what should be the second line? I think LSH10, what we used to discuss, has missed the bus, because the PFS only in ESR is around 5 months only. But now, as you see, when you combine with the targeted therapy, this PFS goes to 9 to 10 months. So 2 studies, giredestrant study, what we say, IF-ERA, and a Victoria study, which is gedatolisib, which is a PAM inhibitor, PIK3P, AKT, MS, mTOR. So this is a PAM inhibitor. That now I'll also be asking you a question, that do you require a ESR mutation when I tell you the results of these studies? Because there was an advantage irrespective of the patient was ESR mutant or not. It is not a single cert, but a combination. So this was a landscape before SABCS 2025. When they progress on CDK4/6, we do switch maintenance. For BRCA, we can use olaparib. If it is ESR, single agent elacestrant, or if it is PIK3, then we give fulvestrant, capivasertib, or fulvestrant, alpelisib. But so let me discuss 2 data. These were all chemotherapy pure. So they had not taken chemo, but had taken 2 or less than 2 lines of endocrine therapy in the advanced breast cancer. That what I have not put it, at least 6 months of CDK4/6. So they have tried to that churn out that very bad patient who progresses within 6 months of CDK4/6. Giredestrant plus everolimus versus standard of care plus everolimus. Now, when you look into the primary endpoint, which was the progression-free survival, remember this 9 to 10 months, because I will be comparing with other trial in a ESR mutant, and when you look into intent to treat, which was ESR and non-ESR, it was around 9 months only. Now, for those with ESR, it benefited, but what was heartening was, even if you are ESR1 non-mutant, there was a hazard ratio of 0.78. So this drug can be given, or a combination can be given, irrespective of the ESR mutation in the second line. Side effects, again, very non-toxic, I can say, and a very safe safety profile. Now, this is a slide which we should remember. If I give a single agent SERD, 60% progresses in the first 6 months. So by adding a targeted therapy, this progression from 60 goes to 30. So I am able to salvage 30%, or not salvage, but reduce the risk of progression when I give it with the combination. So probably SERD with a targeted is a ways to go post CDK4/6 inhibitor. The second study was a Victoria study. Actually, there is a lot of discussion about it. Is you have a 3-line drug. So gedatolisib, which is a IV palbociclib, which is oral, and fulvestrant to IM. So how can you manage a patient giving all the three forms of treatment? Same subset of patient, CDK4/6 progression less than or equal to 2 lines of hormonal. More importantly, no chemo, but they were pick. Please remember, pick 3. They were wild type, not mutant. We have to get that data of mutant. So this was wild. So ESR, non-ESR. And they looked at blinded independent center review between 3 versus 1 drug which was there. Now, when you look into the progression-free survival versus triplet versus doublet, 2 months single agent fulvestrant versus 9.3 months with gedatolisib with palbo and fulvestrant. And when you look into the OS, it reaches to 2 years, which is highly statistically significant. So if you look into PFS 0.24, 70-80% improvement. And when you look into OS, this was also, there is a trend now. Probably it has not shown, but yes, we look at, because there are a lot of crossovers present. So this was a scenario before SABCS. Emerald single agent, the PFS was around 5 months. Serena 2, around, if you say, around 6 months. Ember 3 was discussed in detail, and don't have a time. ESCO 2025, it reached 9 to 10 months. It was those who progresses on CDK4/6, majority were palbo. Some were even Abina, combining Abina with imlunestrant. So it gave you 9 to 10 months of PFS, then Capitello for pick 3, and final, these were pick 3. Now, what we get now is, these are the things we got. So you have 2 good studies, which equally shows that when you combine your SERT with either mTOR inhibitor, or you combine it with your PAM with gedatolisib, and in Ember 3, in ABIMA, these 3 studies really tell us that you need to combine. That is why even Emerald elacestrant, there was a phase 2 data in this SABCS where they combine it now with a CDK4/6 in continuation, and there was a PFS, although it was phase 2, so I did not discuss. So the bottom line now is, irrespective. So now comes the question to everyone: should I start doing my ESR mutation, or should I stop doing it? So please continue doing it better, because the quantum of benefit in ESR is better than non-ESR. So it will help you in telling that the drug will work for a longer period of time. So this was old, and this is not the new thing. So all these green things now are added options now, which will probably in future. So this wheel is again becoming exciting in a second line, which first line was always that good. But if you see, there is now this, it will be, you have 4 SERT. You have amulestrant, you have giredestrant, you have elastrant, and there is one more which I am following, and there is a protect, which is videgestrant. So you have so many drugs there, and now you will be short of choices in the future. So my third thoughts are, combination therapy, SERT, fulvestrant plus targeted, is better than SERT post projection on a CDK4/6, ESR plus or minus both, it is there. But again, you have 4 SERTs, how to choose. Now again, see in next 3 years, we'll choose which is I am better. And what should be the ideal third line? Maybe that TDXD or something, or chemo, or now again we will start discussing third. Second line is nowadays started becoming clear how to use it. So a big thumbs up, yes, these are things. The last part, neoadjuvant, GPAR-6-TO, CALGB, brightness, so many studies which showed that adding carboplatin is better. Now we wanted to know in adjuvant. So 2 phase 3 data in a single, SABS citrine and RJBC 1501. Both were phase 3, EC followed by taxane, EC followed by carbo with taxane. One was weekly and other was weekly versus 3 weekly. So these were the patient, please remember, were a bit high risk. So that is what I understood. Node positive, more than 1 centimeter with a Ki-67 of more than 50. These were the criteria too. Because of 15 minutes, I have not put up in detail. So what was the take home? It was equal. There was an improvement in disease-free survival by 5%. There was an improvement in distant disease-free survival by 5%. And there was a overall survival advantage important. So 4 studies now. Korean study in last year ESCO, that was positive. NRG study in this ESCO 25 was negative. And now 2 again positive studies, which shows that if it is a high risk TNBC, add a carboplatin. So I tried to look into it. Why? So these were diverse population in NRG. So these population were mostly high risk. Toxicity definitely slightly more, as we know, but weekly I think we have got adjusted, and I think I have started thinking, dekhiye, in 6 months you'll have a meta-analysis which tell use it. So probably, yes, this is something which we may start adopting it, because now the robot data is coming. So 4 things, take-home messages I have told. So many things. I would have discussed the Destiny 5-9, but again, 15 minutes, I thought these were the most important things which I should discuss. So 4 take-home messages. Tucatinib as maintenance post Cleopatra is an exciting new option, particularly for hormone-negative subset. Giredestrant, probably now Ranbir Kapoor, a new treatment option in the adjuvant setting. Wait for some time, it might be a better more with CDK4/6, and probably in those N2, N3 disease, you might think this might be a good option. Combination of SERDs with targeted therapy, either a CDK continuation or a everolimus, is the best option post-progression second line when they progress in on the first line CDK4/6 inhibition. And last but not the least, in a high-risk TNBC, now there is 3 data, 4 out of 3, adding carbo may have is a valid option, and I think so in a high risk. At least I have started using it whenever possible. So I thank all with my favorite quotes, or what I like the most about Socrates. The secret of change is to focus all your energies, not on fighting the old, but on building the new. I again thank Kunal for a kind invitation.
Thank you, sir. Thank you, Bharat sir, for just getting us through the important data. So, would you use tucatinib post using THP, or would you, if patient is affording for anything, or would you reserve TDXD? So, because do we, again, when new data comes, everybody questions, do we have data of TDXD use post tucatinib?
Sir, I have excellent question. I think so. The data is sparse, but I'll try to sequence it more. Now, if I give TDXD, samjo in the first line, I have a Destiny 09, it is 40 months. So if I give Patina, or I'll do both, I have 43 months, and Destiny 03, 28 months, if you remember, post. So 43 plus 28 is 72. Now I don't have a data, but these are different drugs. So I believe even if you say in the later lines, probably this is a good drug, TDXD, when we sequence. Again, there is no fair data to say, but maybe 24 months and another 28 months. And we know that TDXD is a bit toxic drug, more than a tucatinib is also a bit toxic. But I think so what I have used in last 3-4 patients, whenever it has come, it is good only. Diarrhea, yes, but once you reduce, this is a good drug only. So for me, if I get a negative, hormone negative patient, I think it is a fair option, because 12 months delta, 12.3, is a very big data, and I'm not sure whether patient may be able to take the later line. So yes, for me, this is practice changing, and you'll see in our NCCN also probably, and once the full text comes. So yes, I will reserve my TDXD. I always say that probably in the second line, because this is a way I can make the survival the longest by sequencing it with in a second line, because either of the way it goes from 60 to 75 months. So I may keep it. Now, should I use TDXD in the first line? There is no conclusive data. If you look into all the things, maybe in a PIK3, maybe in the de novo brain mets, maybe in a very high burden liver mets, you might use TDXD in the first line rather than TCHP. But for me, TCHP is the first line which I have used always. I have not started using tucatinib as a maintenance, but I will use it in a hormone negative. In a positive, I am using Petin, a lot of patients now. So future will tell us probably, but yes, I am happy. I am convinced with the data.
Okay, thank you. Thank you very much, sir. We'll move to the last 2 sessions, and for the second last penultimate session, I'll invite Dr. Jagdeep, who's Senior Consultant Director of Medical Oncology at CC Amritsar.
You can add one more feather, sir. It's up to you. You have all the feathers you can add. Good evening.
Good evening, Jagdeep.
So, thank you, sir. Thank you so much. So, I'll share my screen. So my screen is visible and this presentation mode.
Yes.
Thank you, sir. So the thing is that I was just listening to Dr. Vaswani said, so a lot of drugs are coming and we might be facing a challenge which to sequence and when to sequence. And a point will come when nobody will be wrong. You put any drug in any way and numbers n raised to power n. So now my assigned talk is redefining standards, optimizing first line hormone positive, HER2 negative advanced breast cancer treatment CDK4/6 inhibitors. So this one of the treatments since almost 2016-17 we are discussing, almost down the line 1 decade, and we have a lot of any answers to these questions, which to do, when to use, and how to sequence, and when we can re-challenge. So this is always a talk on all the CMEs about the survival benefits with the all different CDK4/6 inhibitors. So now coming what are the complexities in choosing for these when we choose for the patient who are hormone positive, HER2 negative advanced breast cancers, of course. So we all know that patient related goals, that what is the impact on the life, and most important the survival. So patient disease characteristics and how the patient respond to the previous settings. So just 1 second, sir. I don't know how to reduce this. I'm not able to reduce. Yes, sorry. So response to the prior treatment, that patient had whether received any sort of endocrine therapy or any previous CDK4/6 inhibitors. So this how we treat the patient as per the current recommendations from the ESMO guidelines, that patient who are the hormone positive, HER2 negative, metastatics, and without any imminent organ failure. So we go with this combination of endocrine therapy and CDK4/6 inhibitors. And patient who have some organ failure, so chemotherapy is preferred. And if the patient has a disease progression following that chemotherapy, we can use the endocrine partner along with the CDK4/6. So post endocrine plus CDK4/6 inhibitor, the patient has a progression, then we can analyze based on the mutation testing, any risk organ failure, or based on the PIK3 and this ESR mutation. So different options we can use. And at the last, when we are exhausted, we are a chemotherapy in the either form in the TDX, that which initially Dharampal has already discussed. So that is even the hormone positive, HER2 low or ultra low. This is another options. So current standard of treatment in the first line advanced breast cancers. These are the overall results from the various clinical trials in the post-menopause women, and you can see. So Mona Lisa 2 was outnumbered. Outnumbered this Paloma 2 and Monarch. So this was the category 1 recommendation as per the NCCN guidelines, because this was the only trial which showed a survival benefit in the patients who received this in the first line setting with the AI. So now coming, what are the goal of treatment for the advanced breast cancer when we're planning a treatment in patient? So of course, we always discuss about survival, and debate is always goes on PFS versus OS. So of course, so we have we sometimes we are supposed to favor PFS, and when we are talking of PFS, it gives exact magnitude of the benefit of that drug. But of course, overall survival is the gold standard when we are talking in a patient for this breast cancer in advanced disease. So these are two main goals, and while extended survival is a main treatment goal for both clinicians and patients, but this overall is often a secondary endpoint in clinical trials, which most often use a potential misleading surrogate for the PFS. So PFS is not an appropriate surrogate for OS in advanced breast cancers. So there is a lot of pitfalls for this PFS, because there is improvement PFS, which is seldom surrogate for the OS improvement. And sometimes the PFS does not recognize the balance between the benefit and the harm depends not only changes in tumor size, but also on the toxicities. And the other important is the PFS measurements and comparisons subject to error or bias because of the timing of assessment. That's the most important thing. And when we do this assessment, and informative censoring because of the unproven dropouts between the different groups in the RC trials. So the improvement in PFS is widely misunderstood by the patients and the public to imply improvement in the survival. So to date, ribociclib is the only CDK4/6 that has demonstrated a significant overall survival benefit in the first line hormone positive, HER2 negative advanced breast cancer, regardless of combination partner and the menopausal status. So this is the role of action. I'm not going to detail. Basically, it is CDK4, which is more dominant in the breast cancers, and rather than CDK6. And we have The patients who expects more, the breast line cancer, they express more of CDK4 levels as compared to the 6. So that's why there comes a difference in an on and off target binding impact of the activity, the different CDK4/6. So CDK, if you see with the ribo and palbo, they are highly selective for CDK4 and 6, whereas abemaciclib has lower selectivity as compared to the other these, including CDK1 and 9, which may explain the GI toxicity associated with the abemaciclib. And with regards to the potency, this both abemaciclib and ribociclib exert a more potent inhibition of CDK4/6 versus as compared to CDK6. So based on this, we can choose the patient that which complication, which patient profile setting which we'll need to do. This is a relative guide which can guide us that patient can be given a different set of different type of CDK4/6 inhibitor. So now coming, this is one of the most important thing. What is the AUC when we are talking of the CDK4/6? And we can see that CDK4/6 plasma exposure at clinical relevant doses. So with the ribociclib, the AUC under that cover is the highest. That's more than 20,000 as compared to the other things. So at this clinical relevant doses and after adjustment for the differences in the potency against the CDK4, ribo is expected to provide a better CDK4 inhibition than either palbociclib or abemaciclib in the preclinical studies. So what our guideline states, so you can see with the NCCN, so they have rated as a category 1 recommendation of CDK4/6 inhibitor with aromatase inhibitor for the ribociclib as compared to the abema palbo in the patients in the first line setting. But in comparison with the fulvestrant, if we give, so both ribo and abema, they are given the category 1 recommendations. So coming to this MCBS score that reflect the positive benefit of the treatment with the ribociclib regardless of the endocrine treatment or the menopause status, we can see the ribociclib out numbers every time this abemaciclib. So we always discuss this is a sort of MCBS score in the ESMO that is which shows that the ribo will be a better as compared to the other trials. So coming to this ABC 6 and 7 guidelines, so CDK4/6 are the first line standard of care, and it has shown that ribociclib showed the overall survival benefits, while the other CDK4/6 remain an option. There is a numerical benefit, but statistically significant was not shown by this. So these guidelines, they said that treatment of the hormone positive, HER2 negative advanced breast cancer has several advances. This ribociclib combination have shown a statistically significant and meaningful benefit in OS as well as a PFS, both in pre and post-menopausal women and men. Other CDK4/6 inhibitor remains an option based on the patient comorbidity, tolerance, and availability. So now coming to the quality of life and safety profile to the patient. So you can see the patient who receive this different type of CDK4/6 inhibitor. So the maintained quality of life is seen with almost all the different classes of CDK4/6. And with coming to the clinical improvement in the pain score, it is much more with the palbociclib and this ribociclib as compared to the abemaciclib. The statistically significant delay in the time to deterioration was more evident in the palbociclib and in the ribociclib. And again, diarrhea, which was more in the abemaciclib, that was not seen or reported in the other this CDK4/6 inhibitor. And again, maintenance of work productivity, it was maintained with the again ribociclib in the Mona Lisa 7 trial. So this gives a rough idea. So which will be a better drug in a different subset of patient. So again, coming to most common adverse event as per the product monograph in patient with advanced breast cancers. So GI adverse events seen with the abemaciclib may be the result of its higher off-label target inhibition as compared to the CDK4/6. We have seen a neutropenia, or what you can see the myelosuppression with the CDK4/6, that is a palbociclib or ribociclib, but the significant febrile neutropenia is very less than 1 to 2% in all these patients in all the different trials. So this coming to again a matched indirect comparison of the quality of life analysis of the first line abema and ribo in combination with the aromatase inhibitor. So this is an indirect comparison. So although inclusion and exclusion criteria were generally similar, patients enrolled in the MONALEESA 2 trial were only included in the analysis if they also met the criteria which the Monarch 3 has. And patient in the each arm of Molazar 2 were matched and weighted separately so that the baseline characteristics matched those of patient in the corresponding abdomen and palbocil arm in the monarch 3. So this showed that the patient, the quality of life analysis in the patient who received the first line ribo versus with the ABMA, it has been seen that time to significant duration significantly improved with the ribo as compared to the ABMA. And it did not favor ABMA plus AI over the ribo plus AI in any functional or symptomatic scale. And there was no significant difference were observed in any of the URTC, QLC, C30 or BR23 functional domain, including the global health. So summary of time to chemotherapy after study drug discontinuation occurs at different CDK4/6 trials. You can see with the all these CDK4/6 when patient are exposed. So there is a significant delay in that time to chemotherapy, irrespective of either this palbociclib, abemaciclib, or ribociclib. So that this again I discussed that neutropenia with CDK4/6 inhibitors with along with the endocrine therapy versus combination chemotherapy. So despite we have a grade 3 or 4 neutropenia, but febrile neutropenia is reported less than 3 to 5%. And regardless of this severity, the infection risk is much lower during neutropenia secondary to the CDK4/6 inhibitor as compared with the chemotherapy. And the different biological mechanisms are responsible for the neutropenia caused by these CDK4/6 inhibitors versus chemotherapy and may allow for a more rapid recovery after treatment discontinues. So this right choice studies clearly indicate that patient who received this ribo plus endocrine therapy resulted in higher rates of grade 3 for neutropenia as compared to chemotherapy. But the febrile neutropenia were reported, almost no case was reported in the ribo arm as compared to the chemo, which showed a 3% patient. So infections were also less in the ribo arm as compared to the combo chemo arm. So now coming to this is one of the most important patient category, that is the elderly patient, how we place the CDK4/6 inhibitors. So just one case model which showed that a 76-year-old female treated having a advanced breast cancer, hormone positive, HER2 negative, treated with the endocrine therapy for previous 5 years and currently presenting with the invasive carcinoma, and imaging confirmed the metastasis to the thoracic vertebrae with a good performance status, and of course the comorbidities of hypertension, diabetes, which were well controlled, but no evidence of any organ damage. So what is the treatment of goal in these patients? Of course, elderly patients, when we are talking, so we have to see the first the fitness, and patient have a lot of comorbidities. So these are things has to be taken into consideration when we prescribe a treatment to the patient. So an elderly patient with a good performance status who's fit should be prescribed the standard of care treatment with the CDK4/6 inhibitors plus aromatase inhibitors. In most cases, ribo in combination with AI remains the preferred choice based on the totality of the evidence, that is the PFS, OS, and the quality of life. So initially we were a bit scared that whether palbo is better tolerable as compared to the ribo, but there was a study which has compared that ribo 400 milligram per day, which almost gives the same, you can say, equivalent outcome as compared to 600, and that could be started in the patient who are elderly. So ribo stands good because we have a good data, and even with the 400 milligram, the PFS and OS data that is maintained with the patients in those subset. So coming to this again, that the ribo plus endocrine consistently achieved a more than 5-year median OS across all age groups. So safety profile was consistent again across all age groups, and they were manageable using a dose modification guidance. And in one of the real world Rebana study, this ribociclib plus endocrine therapy delivered a consistent efficacy and safety profile independent of the age. So this ribociclib plus endocrine therapy delivered a consistent efficacy and safety profile. And this was one of the real world and diverse population analysis. So you can see that is in the Rebana and the complement 1 trial, which showed a delivered consistency, efficacy, and manageable toxicity again seen with the same, and good improvement in the profile was reported in the Rebana study. So with respect to the complement adverse event, which was a phase 3B study, with the ribosylib across the extended age groups, and it was seen that adverse events were similar across all age groups and they were manageable. And a greater proportion of the adverse event leading to a treatment discontinuation was observed in patient age 65 to less than 75 years and more than 75 years compared with those less than 65 years of age. And slight higher percentage of patients had a fatal SAEs in more than 75 years of age. So this Ribana, this real world effectiveness and safety for the ribosysleep, which was a prospective non-intervention study which assessed the efficacy and safety of this ribo plus endocrine therapy or the endocrine therapy alone or the chemotherapy in the first line setting in the different menopausal status with the HER2 negative hormone positive advanced breast cancer is going on. In the fifth interim analysis, this the neutropenia was similar in all the overall population and elderly patients who were exposed to the ribosysleep. So coming to the overall survival fact size in the elderly patient treated with the abemaciclib plus endocrine, you can say there is currently no analysis on the length of overall survival achieved in the different age groups in the Monarch 2 and 3. Although there was no statistically significant overall survival benefit in the elderly, but subgroup analysis showed that an OS effect size regardless of age in the both trials.
Sorry to interrupt, sir. Kindly
Uh,
conclude.
Sure. So, and the exploratory analysis found elderly female patients, they experienced a higher rate of adverse events. So this is again coming to the special patient who are having visceral disease. So we have a good this right choice study which has shown that the ribosysleep along with the AI in the patient with the premenopausal, that is a more better option as compared to the chemotherapy, acting in the same span of time with a good outcome. So you can see the median PFS with the ribo plus ET is 21.8 months versus combo chemo is 12.8 months. And it has been shown superior as compared to the combo chemotherapy. So this was a direct head-to-head phase 2 right choice study in patient with a pre and perimenopausal study with aggressive disease. So coming again to the quality of life, which has improved with the patient who received this ribo plus C2 as compared to the combo chemotherapy in this complement. So which again emphasize that in the right choice, first line ribosysleep and endocrine therapy remains the treatment of option for those patients. So no significant difference in the median OS with the abemaciclib plus NSI or versus NSI alone was seen. And overall 53% patient in the Monarch 3 had a visceral metastasis. So it showed that it's an indirect comparison that a patient who had received ribo plus CT, they tend to do a better as compared to the abema, but it is not a head-to-head trial. So again, coming from the palbociclib group, so they again did not show a significant benefit or overall survival for the palbociclib plus ET versus ET alone. And overall 48% patient treated with the palbociclib in the plasma and 59% patient had a visceral metastasis. So to summarize, that CDK4/6 inhibitor plus aromatase has now become the standard of care for the first line treatment in the hormone positive HER2-negative advanced breast cancer. Difference in on and off target binding of different CDK4/6 impact the activity and safety profile. And survival and quality of life remains the goal of treatment in these advanced breast cancer patients. Mona Lisa trials with riboside were the only trials to show a statistically significant clinical meaningful first-line oral survival benefit across all three pre-specified analyses, regardless of menopausal status or combination agents, and consistent OS benefit with the riboside patient with the visceral metastasis, and more than 5-year median OS benefit seen across all age group with pronounced median time to median inpatient and post-progression first-line riboside continue, it can be an option to get an optimal OS benefit. I think this summarizes my talk.
Thank you, Dr. Jagdeep, for taking us through the CDK4/6 inhibitors in first line ABC. So out of 10 patients that you see with metastatic breast cancer, what is the distribution of different CDK4/6? Not today, not for today, but
no. Sir, on an honest note, 10 out of 10 is for ribo in my patient opening.
Oh, good. Great. That is great.
Sir, I recently put some 6 patients on adjuvant ribosysleep. Abemaciclib, I have used only 1 patient, but I don't know why I had a complication of GI, though I should not get so much scared, but I was reluctant to use.
Right. Okay, great. So moving to the
Thank you,
last
sir.
talk. Thank you very much. Last talk for today's webinar. Can I invite Dr. Neha Gupta?
Hello, good evening, sir.
Good evening.
Thank you so much, sir, for inviting me. Is it visible?
Yes, you need to just make it in the slideshow mode and
One thing.
yes.
Visible, sir?
Yes, visible.
Yes, today we'll be discussing about how to sequence basically to cartinib and TDM1 in HER2 positive metastatic breast cancer. As we all know that we have so many therapies available for HER2 target now in breast cancer. Now just we have to optimize the therapy in a sequence which is very crucial in expanding HER2 targeted options. First, we'll be discussing about the TDM1 in metastatic breast cancer. As we all know that after first line trastuzumab-based therapy, we have TDM1 in the second line, which provides superior efficacy relative to other HER2-based therapies like lapatinib and capecitabine. They are the two main trials, which is Amelia study and the Theresa study, which is done in the second line breast cancer after trastuzumab progression. Prior taxane plus trastuzumab was there, and which are progressing on metastatic treatment or within 6 months of adjuvant treatment. In those patients, they were randomized to TDM1 versus LABCAP till progression. In the study, we can easily see in the Theresa study also same was done in HER2 positive advanced breast cancer who have got already more than 2 prior HER2 directed therapy for advanced breast cancer. In those, they have randomized to TDM1 versus treatment of physician choice therapy. Hello? Hello? Hello?
Hello. Yes, ma'am, we can hear you. Please continue.
Then come in the Amelia study, we have seen PFS was seen by independent review. We can see the curves are separating widely, and there was PFS benefit of 3 months and 6-month benefit in OS when we have used TDM1 versus LABCAP. And similar in the Theresa study, we have seen there was 3 months benefit in PFS and 7-month benefit in OS when we have used TDM1 in the second line settings. These are the few grade 3 side effects which were seen with TDM1 when they were compared with LABCAP. We can see that they were manageable. Discontinuation was seen in 5 to 6% of patients. As with TDM1, the most common side effects we see is hepatotoxicity and thrombocytopenia. We can clearly see that there were 40.8% patients who have side effects with TDM1 versus 57% patients in LABCAP arm. There was little hepatotoxicity, which is seen in TDM1 versus LABCAP. Otherwise, that was manageable. Now, in the second line, we'll be talking much with brain mets, specific with brain mets patient, more than because we already know that HER2 positive metastatic breast cancer patient eventually develop brain mets. So, more than 50% of the patient with HER2 positive metastatic breast cancer may develop brain mets eventually. So, trials have excluded the patient with CNS disease. Now there is a consensus which is going on. Should we do early MRI with in asymptomatic patients who have metastatic breast cancer? Because as we see in lung cancer, that upfront only we get screening MRI done to rule out brain mets. Because of the expanding options available in HER2 positive metastatic breast cancer who have intracranial efficacy much stronger, now there are guidelines who today current guidelines do not recommend practicing of MRI in asymptomatic patients, but yes, because of expanding options of using anti-HER2 agents, this can be a practice changing approach which can be done. But yes, research is going on in this area. It can lead to wider expert agreement in future. Now, what is the definition of stable versus active brain mets? Stable brain mets are patients who have received previous local treatment for the brain mets and have stable CNS disease. And our main goal of treatment in those patients are to prevent the CNS lesion growth and to prevent new CNS mets, that is CNS PFS. Now, in the active brain mets, who have new or progressive brain mets or brain mets who have not received any local treatment. So our main goal is to manage limited brain mets and to treat both CNS and systemic progression. So there is a HER2 study which was done. In that, tucatinib plus trastuzumab plus capecitabine was combined in previously treated metastatic breast cancer patient. This was the largest randomized study which was done so far for the brain mets population. In this, they have taken patients with HER2 positive metastatic breast cancer who have received prior trastuzumab or prior pertuzumab and TDM1. Brain mets were allowed. They have included both previously treated brain mets, untreated mets not needing immediate local treatment, and previously treated brain mets who are progressing but not needing immediate local treatment. In those patients, they are randomized to tucatinib 300 mg BD plus trastuzumab plus capecitabine versus placebo plus trastuzumab plus capecitabine. Our primary endpoint was PFS and secondary endpoint were OS, PFS in brain mets and overall response rate. In this, we can see the median lines of therapy which were given were 3. 97% patients had extracranial mets also, and 70% patients have already received RT for brain mets. In this, we have seen that 48% patients are there with brain mets, out of which 29% were having active brain mets, and 19% were having treated stable brain mets. In this patient, we can see the overall response rate, which was 47% in the patient who had received tucatinib along with trans-2 plus capecitabine, versus 20% response rate in the arm who has received trans-2 plus capecitabine. So by adding tucatinib, there's almost to the tune of 27% increase in the response rate by adding tucatinib. Now come the OS in all patients with the brain mets. We can see easily that there was median OS of 21.6 months versus 12.5 months. Delta of 9.1 months were there when we have combined tucatinib with trans-2 plus capecitabine. This data can be a practice changing in the patient who are having brain mets. Similarly, we can see the CNS PFS rate. In tucatinib plus trans-2 plus capecitabine, the PFS was 9.5 months versus 4.1 months in trans-2 plus cap arm. Delta of nearly 5.4 months we can see. And in OS also, median OS also was very good, 20.7 months versus 12 months, dealt to the tune of delta of 8.7 months. So by adding tucatinib, there was significant 64% reduction in the risk of CNS progression and 50% reduction in the risk of death. So tucatinib-based regimen can become a go-to therapy for our patient with active brain mets. Now, this is the data in the stable brain mets. In the stable brain mets also, there is a good CNS PFS of 13.9 months versus 5.6 months, delta of 8.3 months. Similarly, the median OS was 15.7 months versus 13.6 months, delta of 2.1 months. But yeah, in the active brain mets, we can see a huge difference in the median OS. So tucatinib can be basically in the active brain mets. I would recommend tucatinib. In the stable brain mets, we can still go for other options. Now we can see in the new lesion brain-free survival, there are 24.9 months versus 11.1 versus 13.8 months. Delta of 11.1 months for tucatinib plus trans-2 plus capecitabine therapy. Basically, tucatinib can basically defer the local therapy for this. So we can save patients for quality of life related issues arising from the local therapy. Now there's a new data which is already discussed by Dr. Bharat sir. That's HER2CLIMB-05 study which is done in the patients as a maintenance therapy post HER2 plus trans-2 plus chemotherapy followed by maintenance therapy. In those patients, they were if there was no disease progression then they've added tucatinib along with trans-2 plus pertuzumab versus trans-2 plus pertuzumab plus minus endocrine therapy. In this, primary endpoint was PFS and secondary endpoint were OS, PFS, CNS PFS, safety profile. So we can clearly see that when we have added tucatinib along with per2 plus trastuzumab, there was median PFS of 24.9 months versus 16.3 months. So median PFS was significantly longer in patients who are receiving tucatinib plus trastuzumab and pertuzumab. We can also see by the this tucatinib plus trastuzumab plus trastuzumab plus pertuzumab can also add PFS of 12 months of median PFS benefit, which was observed with tucatinib. So tucatinib can be added along with per2 plus trastuzumab in all those patients who have not progressed on this therapy. OS data were immature. OS events were numerically lower among patients receiving tucatinib. So there was OS of 8.5 months versus 4.3 months, nearly double the median PFS benefit with tucatinib. And they have also seen that PFS by subgroups. We can easily see that almost there was a median PFS benefit which was observed across all the subgroups, even in the de novo patients, in the recurrent settings, in the ERPR negative and ERPR positive patients. And they have also taken the prior anti-HER2 treatment. We can easily see that almost in all the subgroups, there was a benefit when we have added tucatinib along with trastuzumab plus pertuzumab. In the safety outcome, yes, there is a little safety toxicity which was observed with tucatinib when we have added with trastuzumab plus pertuzumab. The main side effect were hepatic events and diarrhea, which was observed with tucatinib as compared to per2 plus trastuzumab arm. So 49.4% patient had to hold their drug, and 29.1% patient had to reduce the dose of tucatinib. But there was no evidence of any new safety signals. This is the study which was already discussed by Sir. Patina study. In this, they have taken the patient with HER2 positive and hormone receptor positive metastatic breast cancer patients, and also brain mets were allowed, but no prior treatment beyond induction. Treatment was given for 6 to 8 cycles, and then no disease progression was should be there for more than 6 months after induction therapy, and no prior CDK4/6 inhibitor should be taken. In those patients, they have stratified by into palbo plus trastuzumab plus pertuzumab plus endocrine therapy versus trans2 per2 plus endocrine therapy. Our primary
Dr. Neha, ma'am, great presentation. Can we request you to conclude, please?
Yeah. So we can, as already discussed, there was median PFS of 44.3 months as compared to 29.1 months. The last study, which was TDM1 plus tucatinib. So by adding tucatinib along with TDM1, especially in the active brain mets, there was a median PFS of 7.8 months and OS is immature, still to be discussed. So at the end, I would just conclude that yes, now in the active brain mets in the second line therapy, we can go for tucatinib plus trastuzumab plus capecitabine. Thank you.
Thank you very much, Dr. Neha, for taking us through the role of tucatinib, which is now upcoming, and because of its availability, we are able to use it in this difficult to treat population. So I'll just thank all the speakers, moderators, panelists, and just summing up today's session. We started with the HER2 positive early breast cancer, where we saw we can kind of de-escalate by omitting carboplatin or by using nab-paclitaxel instead of docetaxel and use dual anti-HER2. Then we had a good discussion on post-mastectomy radiotherapy and looked at indications where we can avoid it. Then there was TDXD. We know it's upcoming in a lot of indications and also in newer subset, which is HER2 low and ultra low. And that was a great panel discussion by Dr. Jatin Sareen on HER2 positive early breast cancer, where we saw dual anti-HER2 continuing post surgery and anthracycline versus no anthracycline. Good debate was there. And then excellent talk by Dr. Bharat, where we saw use of carboplatin in adjuvant setting in triple negative breast cancer, HER2 climb 05, which has been just discussed again also, and also the lidera trial, where I was trying to get Dr. Aditya Bardia to present, but unfortunately we could not get him. He was the lead author and presenter at SABCS also. So giredestrant, which is the newer molecule in adjuvant setting. And then the last two sessions where we saw role of CDK4/6 inhibitor with the aromatase inhibitor in advanced breast cancer, how ribociclib scores over the others, and also in the end the tucatinib and its benefit in HER2 positive, especially difficult to treat CNS positive disease. So with that, I'll thank everyone and also the tech support team and Tarunji. So good night, everyone. Thank you once again. We'll see you all tomorrow again, 6:50. We are starting a little early, 6:50 p.m. Thank you.
Thank you, sir.
Thank you, Dr. Kunal sir, for such a wonderful sessions today. And from all of us, from the organizing team, my colleagues, Daud and Vishal, goodbye. Thank you. We meet again tomorrow at 6:50. Thank you so much.
Yeah,
Support
thank
team.
you to all the Spencers also. Thank you.
Thank you. Good night, sir.
Thank
Good
you,
night.
sir.